All right, welcome everyone. Welcome on a Saturday morning to Real World Ophthalmology Summit. My name is Dr. Rishi Singh, and this is culminates many years of doing this summit with my co-moderators, Dr. Durga Borkar and Dr. Brian Vanderbeek, on talking about some real-world applications of data, how we're using data in today's environment. Here are our learning objectives. We're going to describe the strengths and limitations of electronic health record data and other data sources in real-world studies, evaluate how AI and machine learning algorithms have helped our real-world studies, and also looking at real world imaging, which is really becoming avant-garde. Many of us are keeping repositories now. We have large repositories of data that might be available to us. And we're going to talk about some of those imaging findings and features of real world studies. And we're going to develop a detailed you all today, your presenters. We have some abstract presenters as well, and they'll cover all aspects of retina and other disease states as well. And we'll also explore some practice gaps, some of the areas we really need help with, standardization, maybe nomenclature, things like that, that we're going to talk about as a team today and discuss what we all can work and strive toward in this. And this activity is supported by an independent medical education grant from Regeneron, Genentech, and ANI Pharmaceuticals. And we want to thank them for their participation. Without them, this webinar would not be possible. We're joined today by Dr. Durga Borkar. She's at the Duke Eye Center in Durham, North Carolina. I'm Dr. Rishi Singh. I'm at the Mass Pioneer and Mass General Brigham in Boston, Massachusetts. And Dr. Brian Vanderbeek, he's over at the Shea Eye Institute in the University of Pennsylvania. And they'll be the moderators of our session today as we go along. We have a huge faculty panel of speakers today. I want to thank them all for joining on a Saturday and giving away their precious time with us to enlighten us on their real world studies. And here we have our abstract presenters, which were selected from a very large lot. Enjoyed seeing all the submissions this year, and these are the ones who made the cut, and they're going to present to us at the end of today as well. So with that, I want to again thank our sponsors, Astellas, Regeneron, and Genentech for their sponsorship of today's program. And this is a live webinar again, so please use your Q&A icon to enter questions. We'll be happy to take questions for you during this program today. Our goal is to provide as much data as we can to you all and answer all of your questions during the webinar. We'll have some live panel discussions at the end of each of the talks as well, so we'll be able to answer any of your questions you have. So let's get started with our first presentation, and that's going to be by the section we're going to call Intro to Datasets and Applied Methods. And the first speaker for this section will be Dr. Preeti Rao. She's going to talk about real-world interoperative surgical parameters in Eye Intelligence Cloud, a national surgical database of US VR surgeons. Thank you, Preeti.
Hey, thank you so much, Rishi, for the invitation. So these are my financial disclosures. So we're going to talk about the what the Eye Intelligence Cloud database is, and then we're going to look at three uses of this database for practical applications, and then talk about kind of future uses of this data set. So, large scale clinical database exists for surgical outcomes, and we're talking about Iris Registry, Vestrum, Trinetics, and these are based on clinical parameters, visual outcomes, and anatomical outcomes. But what actually happens during surgery? The problem is we don't have any baseline intraoperative measures to actually quantify what happens during surgery. So what this iTelligence Cloud is it's a national surgical database of Stellaris machines in the US by vitreoretinal surgeons, and it's a collection of intraoperative surgical parameters that are used during vitrectomy cases. So these are some examples of baseline parameters, including infusion pressure, vitrectomy time, vacuum pressures, laser settings, and coagulation settings. And so the first kind of iteration of this data set was to really define the baseline surgical parameters in this iCloud database. And we wanted to identify specific surgical parameters that were correlating with duration and complexity of cases. So we looked at a retrospective review of all these surgical cases in this iCloud database. And this included all cases requiring a vitrectomy between 2018 and 2024. And what our exclusion criteria are obviously cases that had no vitrectomy or infusion times less than 3 minutes, so accidental turning on of the machine. And this sample size included 100,000 cases. Those cases that were less than 1 hour were 75%. Those that took greater than 1 hour were 25% of the database. And we found the mean case duration of all these cases were about 47 minutes. And those that took less than an hour is about 30 minutes of time. And what we found out in these baseline surgical parameters, the mean pressure was 47 millimeters of mercury. The vacuum pressure was about 400 millimeters of mercury, and the cut rate is about 6,000 on average. When we break it down by surgical time, those cases that took less than 1 hour tend to have higher infusion pressures, higher vacuum pressures, as well as lower vacuum time. But when we look at additional markers of complexity, one thing we want to look at is infusion pressure. And what we found is that mean infusion pressure is about 47 millimeters of mercury. This is not to be confused with intraocular pressure, as Stellaris machines tend to use higher infusion pressures. When we looked at case duration, those that had less than 1 hour of cases tend to use higher infusion pressures. And when we looked at a breakdown of percentage of cases that used elevated infusion pressure time, cases that took it greater than 1 hour tend to use a higher percentage of elevated infusion pressures. And in those cases that actually use the elevated infusion pressure, cases that took greater than 1 hour tend to use higher elevated infusion pressure absolute values compared to less than 1 hour. And in cases that tend to use the elevated infusion pressure, we found that cases greater than 1 hour tend to be on this elevated infusion pressure function twice as long as those that took less than 1 hour, consistent of what we think. Now, what we also wanted to look at additional markers of complexity. So we looked at a subset analysis of all vitrectomies using endolaser and coagulation. So cases that tend to use cases that tend to reflect retinal detachment outcomes or diabetics, and this comprised about 35,000 cases. When we looked at this complex Spearman correlation matrix that looked at markers of complexity, what we found is longer case duration tended have longer vitrectomy times, longer laser duration, a higher energy power, whereas shorter cases tend to have higher vacuum pressures and shorter vacuum times. And these kind of parameters also reflect the larger data set. And we looked at infusion pressure, similar outcomes. Cases that took greater than 1 hour tend to use a higher elevated infusion pressure setting. And when we looked at laser settings, cases that took less than 1 hour tend to have lower total energy, and as well as coagulation settings tend to use higher power time and lower duration. We talked about kind of higher order data entry databases. Now we want to look at the third use, which is looking at surgical markers and postoperative outcomes. So Mania Redding was our Baylor resident and now a fellow at Oregon. She looked at surgical parameters and postoperative retinal detachment outcomes. And what we used as inclusion criteria is all primary retinal detachments undergoing a vitrectomy at our practice with 3-month follow-up. And we wanted to link these correlation parameters with visual acuity and retinal detachment rates. And what we found that is that there was no difference in parameters and primary success rate. However, when we looked at it in terms of macular off status and visual acuity, those that had better visual acuity tend to have lower laser power compared to those that end up achieving less 20, 50 or less at 3 months. So the next steps is to look at a multivariable analysis. So in conclusion, this database is really nice to define baseline surgical parameters in a national setting. And so we really want to standardize what our national surgical parameters are that we're using and to be able to correlate them clinically with retinal detachment pair, practice setting, time in practice. And so the future uses are to link this database with IOL master OCT data images that Rishi alluded to. And so I wanted to thank our co-sponsors and our collaborators. Thank you very much.
Thank you, Preeti. So we're going to get to some questions in the panel discussion, so please hang on. We'd love to have you come back at that time for some questions. And we're going to turn over to the next talk. That talk is going to be by Dr. Tobias Els. He's going to speak about imaging repositories.
Yeah, thank you very much. Try to proceed slides. It seems not to proceed. Oh, no, maybe it's just a delay. So thanks a lot. Yeah, thanks for having me. I'd like to talk about our institutional imaging and data repository at Mass Eye and Ear. What's inside? how we have done it, maybe also as an inspiration for other sites. Yes. A delay. Okay, no, yeah. So speaking of real world data, actually we at our hospital systems, we are sitting on a treasure. And our treasure, this is not like crude oil, as in this case here. Our treasure is the enormous amount of existing patient data in our systems. And similarly to the oil, it's hidden in the ground. So our data is hidden in imaging systems, on medical devices, and in database systems. So we need to develop our own drilling equipment to get the data usable for research purposes. And we at Mass Eye Ear, for this purpose, we teamed up. So it's a bit slow. I'm sorry. I'm trying to proceed. Oh, no. So we teamed up. So this is Dr. John Miller as the Director of Retinal Imaging, Dr. Nasri Zebadas, Director of Glaucoma Imaging, and myself on the implementational side to set up the Mass Eye and Ear data repository with a goal to combine all existing patient data ever obtained at our hospital and make them accessible for research purposes. And these data come from different sources, mainly from the medical record from our EPIC system and 3 different PACS systems. What are PACS systems? PACS systems, this stands for Picture Archiving and Communication Systems. Yeah, here we go. These are those centralized systems where all the different medical devices project their data into, and they retrieve, manage, and share medical images such as Forum from Zeiss, Harmony from Topcon, HiX2 from Heidelberg Engineering. Most clinicians associate their own web clients with these systems, which they can use in their offices to pull data from their own patients and visualize their measurements. This is great, but it's nearly unusable for large-scale data export. So, sorry, now proceeded without, anyway, so for large-scale data export. So what we are doing instead of using the front ends, we develop software for using the back ends. Okay, so the first component of the repository is EPIC for medical records, which we access through the SQL backend in a fully automated way to get data from our over 2 million patients at Mass Eye Ear, such as demographics, history of diagnoses, and the most important ophthalmic measurements such as IOP, cup-to-disc ratio, and so on, and also the unstructured medical notes, of which we already exported over 250 million for our 2 million patients. It's almost scaring how much information is available on a single patient in a hospital system. So it should, yeah. Then we access the Forum PACS system for all Zeiss devices in a fully automated way, self-developed, so without any human interaction. Every weekend, we pull all the new scans. So far, we pulled over 500,000 Humphrey visual fields and over 1.3 million Cirrus OCTs from the Forum system. The second PACS system which we access is Harmony. This is a system from Topcon. Exactly in the same way, we use it for exporting fundus images with so far over 4 million images imported from a dozen of different camera systems. Then finally, we access the HiX2 PACS system from Heidelberg, mainly for Spectralis device with already over 2 million Spectralis scans imported. And all these different data from these different devices, modalities, PACS systems, etc., we are linked to each other and searchable, so you can query their metadata. And finally, just a few words about the administrative procedure. How do we manage the whole thing? So we have a dedicated IRB just for the generation and the maintenance of the repository itself, which does not allow yet to use the data for research purposes. If anyone would like to use repository data for their own research project, including ourselves, by the way, we need separate IRBs for that project. And we, as the gatekeepers of the repository, would then give access to precisely that subset of the data, which is approved by the respective IRB. As you can imagine, this is a gold mine for research, and it's heavily used. Just as an example, I scanned the ARVO abstracts of the prior 2 years and found 38 abstracts which used our repository. Thank you for your attention.
Thank you. Thank you, Tobias. We're going to obviously have some questions for you when we get to the next section. So we're going to turn over to Dr. Tom Chula. He's going to talk about the Vestrum Health Retina Database. And thank you, Tom, for joining us this morning.
Thank you, Rishi, for having me. Today, I'm going to discuss the ins and outs of EHR databases, as Rishi said, focusing on the Vestrum Health Retina Database. Can I have the next slide? Perfect. Thank you. I'm very excited about the potential for real-world data in ophthalmology. So today, I'll briefly cover why is real-world data important, claims data versus EHR data, common current databases focusing on the Vestrum Health Retina Database, Vestrum services for industry, and finally, Vestrum services for physicians, including some of my own learnings from performing research with this system. Next slide, please. Given the ability to scale, real-world data is important for numerous applications, including natural history studies, benchmarking for practice improvement and value-based care, clinical research, including retrospective studies, clinical site selection, and patient identification, as well as providing commercial insights. Next slide, please. While claims data may be well-structured, EHR data provides important clinical nuances and details. EHR data is generally rich with history, exam findings, and treatment details. Next slide, please. The IRIS registry is the nation's first comprehensive eye disease clinical registry. Participating U.S. Academy members benefit through quality measures reporting for Medicare's merit-based incentive payment system, for example. Next slide. In 2023, Retina Consultants of America and Retina AI announced a collaboration to develop a real-world evidence database. Next slide. Today, I'm going to focus on the Vestrum Health Retina Database, which is now part of PPD Thermo Fisher Scientific. Importantly, as a retina specialist database, this database differs from the IRIS registry, which includes all specialties. Next slide. The system includes a panel of over 380 U.S. retina physicians, and it's geographically diverse. It includes 2.8 million unique patients and over 18 million patient visits. Like the IRIS registry, available data includes patient history, visual acuity, intraocular pressure, exam findings, diagnosis, and treatment. Like many EHR databases, however, there's limited ability to query imaging. Next slide. These databases de-identify data and aggregate it in a HIPAA-compliant, secure fashion. The Vestrum system provides various data-driven products such as market research, industry analytics, and physician practice information. Next slide. These are some of the real-world evidence offerings. In the next slide, I'll first cover services for industry and then services for physicians, where I'll spend most of the time. Next slide. There are various services for industry. First, for commercial and market access, there's a comprehensive view of the retina landscape, enabling companies to track shifts over time. In health economics, outcomes research, and medical affairs, the system reveals the incidence, prevalence, and comparative effectiveness of treatments and supports outcomes analysis. For clinical trial recruitment, the database helps identify ideal physicians and patients, streamlining recruitment efforts. Next slide. There are also multiple services for physicians. Actually, one back, please. There are also multiple services for physicians. One service of note includes the Recruitment Acceleration Program, which mines practice EHR data to identify potential patients for a specific trial. Next slide. In general, approximately 80% of inclusion and exclusion criteria can be automatically queried across the EHR data. Also, the Vestrum team can perform chart reviews to look for exclusionary criteria that's not programmable. Next slide. This is an example of programmable eligibility parameters with both inclusion and exclusion criteria for a typical wet AMD trial. Next slide. In addition to clinical trial recruitment, the system provides benchmarking reports, including comparison with regional and national benchmarks. Next slide. For example, this system provides dashboards on patient volumes, procedure volumes, medication use, and outcomes data. With this tool, practice administrators can efficiently summarize practice performance. Next slide, please. Finally, I want to focus on clinical research. Physicians can access the data needed for review, analysis, and research. Next slide. For example, using this system, I've previously presented and published on clinical practice outcomes in over 100,000 patients with neovascular AMD, DME, and RVO-associated macular edema. Just this year, I published a study on over 18,000 untreated eyes with geographic atrophy, showing a loss of 2 to 3 lines of visual acuity within 36 months of follow-up. Next, please. A limitation of these EHR-based systems involves a key endpoint, visual acuity. In practice, visual acuity is often measured via Snellen chart without standardized protocol refractions. The formula shown here is often used to convert Snellen visual acuity into an ETDRS approximation, but obviously this can't compare to a standardized ETDRS protocol refraction. Next slide. Importantly, I want to point out that clinical research using EHR databases has additional limitations beyond this non-standard visual acuity. These studies are retrospective with limited controls. Furthermore, there's limited ability to tailor inclusion and exclusion criteria compared to the explicit criteria in randomized clinical trials. Finally, imaging is generally not standardized, and there's currently limited ability to query imaging data. Next slide. In summary, there is a great potential for real-world data in ophthalmology. These systems can generate important services for industry, for commercial and market access, health economics, outcomes research, and medical affairs. These systems can also generate important services for physician practices, including clinical trial recruitment, practice benchmarking, and clinical research. Next slide. Thank you very much for your attention.
Thank you, Tom. That was a great presentation. A lot of great data that's come out of obviously your work and the papers that you highlighted. So I appreciate you coming and speaking on that. And we're going to get to some questions for you at the end. We're going to turn over to now Dr. Josh Stein, who's going to speak on the source database. Josh?
Good morning. Good morning, everyone, and kudos Rishi, Durga, and Brian for putting together such a wonderful symposium. I really appreciate the opportunity to speak today. These are my financial disclosures. So SOURCE stands for the Site Outcomes Research Collaborative. It's a consortium of academic ophthalmology departments, all of whom are on the EPIC electronic health record system that are contributing data on all eye care recipients seen at their institutions. Several years ago, my colleagues and I at University of Michigan went through the EPIC EHR and wrote code that would grab all the patient demographics, all the structured data fields, visions, eye pressures, fundus exams, all the billing and administrative data. We have patient report outcome data, lab data, pathology data, surgical data, medication data. At the end of that process, we were able to pull all the data from our EHR. And then we started reaching out to colleagues at other sites that are also on Epic and sharing our code with them so they could pull their data in the same manner. We have software that removes all their protected health information so sites can send their data into our data center where we pool, clean, harmonize, aggregate the data. We can link in data from ocular imaging and diagnostic tests like visual fields and OCT. We're working on adding genomic data in and basically creating a pooled repository that can be made useful for research and quality improvement projects. Presently, we have 23 active sites in the SOURCE consortium. These sites have shared all their historical data from when they went live on Epic up to the present and going forward. These are another 14 sites that are in the process of sending their data into SOURCE, and I anticipate several of these sites will be fully on board by the end of the year. And these are all the sites throughout the country that are at different stages of getting involved with SOURCE. It's a nice geographically diverse set of practices and patients and a lot of wealth of useful information. In terms of the data we're able to capture, not only the data captured from the billing codes, but we use tools like natural language processing to parse out all the relevant details. So if a researcher is interested in finding patients with disc hemorrhages or neovascularization of the disc, we're able to identify all those patients. All the patients are eye care recipients, but we're capturing ocular as well as non-ocular information, uh, like if they get their diabetes care at our institutions, we're able to capture that, their rheumatology care, CPT codes for visits, diagnostic therapeutic procedures, a ton of surgical data, the location of the surgery, all the timestamps, preoperative diagnoses, intraoperative supplies and implants, outpatient labs, hemoglobin A1C, uveitis labs, for example, outpatient medication, prescription information. We're able to link the data and source to metadata, so the numeric values tied to OCT, to visual fields, biometry, topography, for example. All the data in source is completely de-identified, and we use date shifting to preserve the chronology. So if a patient had cataract surgery and 2 weeks later developed endophthalmitis, we can capture the chronology of that. We have over 7 million unique eye patients, over 22 million office visits, over a million surgeries, over 2 million macular OCTs, and over a million visual fields in source. The demographics are what you'd expect to see at tertiary care facilities. We have slightly more females than males and a decent number of racial and ethnic minorities. It's actually pretty similar to what you see in the US Census. These are some examples in terms of the granularity of source data for retina macular conditions. We're able to find patients with all this different types of pathology. Even though all the sites are on Epic, I tell people if you've seen one instance of Epic, you've seen one instance of Epic. There's still a lot of need for harmonization. Each site is calling their implant something different, for example. In terms of use cases, clinical studies, outcomes research, machine learning, AI, quality improvement initiatives, and potential patient recruitment for clinical trials. This is an example of a study using machine learning to predict patients needing glaucoma surgery in the next 5 years. These are several other examples of studies by folks throughout the consortium. We have over 8 dozen researchers working with source data, several large NIH grants and foundation grants using source data. We're able to link to other pots of data like social determinant of health data, mortality data, community and neighborhood level data. Here's our website, and happy to answer questions during the Q&A. Thanks
That's
again for
great.
having me.
Yeah, thanks, Josh. Yeah, we're going to have some questions for sure. Our next talk is by Dr. Karen Y. She's going to speak on a review of Trinetics and real-world evidence pros and pitfalls.
Thank you so much for the organizers for having me here today. So what is Trinetics? Per the company's website, it's described as the world's broadest federated network of global real-world data. This is essentially a private company that made this large real-world database with goals of enhancing clinical research efficacy and facilitate industry and academic collaboration. What does that actually mean? So Trinetics is a global federated health research network with over 250 million patients. It has data from actually 200 HCOs in 19 countries and essentially includes all de-identified EHR data, including encounter type, diagnoses, procedures, meds, vaccinations, lab values, and even some genomic information as well. It does have its own built-in statistical web-based platform, and all the data is HIPAA compliant as well. So there's been a boom in different papers coming out utilizing Trinetics. So here on the left, we can see a bar graph of different papers just within ophthalmology that have published Trinetics papers with 70 almost this year in major journals like Ophthalmology, AJO, JAMA O. But this trend is actually also seen in other parts of medicine as well. In 2025, there's been 1,200 papers published within Trinetics mentioning, or within PubMed mentioning Trinetics. Actually, Trinetics just posts on their LinkedIn that they're the most cited EHR database within PubMed this year. So just going a little bit through about some of the different examples, kind of questions that we can ask Trinetics. Here we can ask, we can use Trinetics to look at the effect of different ocular diseases on systemic outcomes. So our group has looked at retinal vein occlusion, retinal artery occlusion, and looked what is the risk of stroke, MI, and death after these different ocular events. We can also apply this to less common diseases. So for example, looking at patients with Marfan syndrome and ocular manifestations, or the role of PVR and keloids as well. Trinetics is also great to look at the different ocular side effects that are related to commonly used systemic medications such as GLP-1s, SGLT2s, or even looking at the role of different anticoagulants in patients who have AMD and risk of conversion to wet AMD. And then you can also use Trinetics for less common medications as well. So here we looked at different ocular side effects from patients who are on these rare cancer treatments like CAR T cell and immune checkpoint inhibitors. So delving into the database a little more, what are the different pros of it? So I think the biggest, most obvious strength of Trinetics is the sheer number of patients on this platform. So there's over 250 million lives and with 70 billion data points, and the data is updated in a live fashion in real time. This makes it really useful to look at new medications coming to the markets, new procedures, and really great for identifying patients with very rare diseases or uncommonly used medications. Because of the sheer size, you can also look for novel associations or subtle effects. Trinetics also uses a web-based platform that has a built-in analytics system, and especially compared to some of the other platforms, it can be relatively quick to use. And I think this is a really great tool for trainees to use, especially those who may have limited time and limited bandwidth. With this database, you don't necessarily need coding experience, which can make it more accessible. And in terms of its built-in analytics system, it does have propensity score matching, allowing users to kind of balance different baseline differences, minimize confounders. You can run only univariate analyses. You can also create Kaplan-Meier analyses to estimate probability of a certain outcome. And then you can download the raw data as well, though I will admit this can be quite tedious. One other nice part of this platform is it does have a built-in study design tool where you can chat and email analysts from Trinetics to kind of ask about different study design creation. So what are some disadvantages? So number one, I think this goes with almost all EMR databases. There's a large dependence on physician coding, physician accuracy coding, and reliance on ICD and billing codes. Unfortunately, there's no way to really confirm this. And prior studies have identified that, there's a large number of ophthalmic procedures may be miscoded, which can limit the reliability of the data. Some diseases are also very poorly represented by ICD-10 codes, which can make it hard, such as thyroid eye disease or MACTEL, for example. Patients may also receive care in outside HCOs that aren't affiliated with Trinetics. And because the data is commonly being constantly updated, sometimes analyses that are conducted at later times can actually change as there is more data added in, and that can create concerns for reproducibility. There's also lack of ophthalmic specific data, unlike source, which we just heard about. There's no IOP, there's no acuity, there's no lacking of imaging. And I think one main limitation as well is there's no laterality for procedures or diagnoses unless these were coded in the ICD-10 diagnosis. The integrated analytics platform is great with Trinetics, but it can cause some issues with the propensity score matching. For example, there can still be residual baseline differences even after matching, and it can overlook confounders, and it's not always clear how Trinetics handles missing or incomplete data. And as with any study, it's really important to be cognizant when designing studies with very good inclusion-exclusion criteria, ability to pick an appropriate index event. It's easy to draw the wrong conclusions and to remember correlation is not causation. And unless you download the data is really only limited to univariate analyses. Last, is Trinetics generalizable to the general population? I think the answer is maybe. Looking at the different HCOs captured in Trinetics, it's mostly larger healthcare organizations, and that can increase the risk for medical surveillance bias. This is because patients studied in Trinetics tend to have higher levels of surveillance and intervention compared to the general population. However, there was one paper that compared Trinetics compared to the US Census, and it found essentially that patients in the Trinetics US network were a little more likely to be older, more likely to be female than the US Census. However, the authors felt this was overall broadly generalizable to the US population. So overall takeaways, Trinetics is great for retrospective cohort observational studies and to look for possible novel associations, examining rare outcomes. But it's important to remember these findings are hypothesis generating, correlations not causation, and there's always going to be a need for larger prospective trials to solidify conclusions. And as Uncle Ben said in Spider-Man, with great power comes great responsibility. Trinetics is a super powerful, robust research database, but we do need a lot of caution and careful thought when designing our studies and interpreting results. Thank you very much.
Thank you, Dr. Y. That was a great presentation. Really appreciate that talk. And we're going to get to the question panel, and I'm sure there'll be some questions about those pearls and pitfalls you discussed at the end. I'm going to turn over to Dr. Tam. He's going to talk about establishing sustainable benchmarks for large language models in ophthalmology.
Thank you, Rishi. Good morning to everyone. It's evening time in Singapore now, and it's a pleasure to be here, to be invited to join this summit. So I'll touch on the evaluation framework for large language models in ophthalmology and what does it mean to have standardized benchmarking for these large language models in the realms of knowledge evaluation, clinical reasoning, and lastly, what are the ways to form robust evaluation? So as we all know, there's a rapid development in the space of language model since the end of 2022 when ChatGPT first came out. But the whole idea of large language model, or rather natural language processing, didn't just happen at the end of 2022. The concept happened way earlier in the 60s, but obviously we have witnessed dramatic, rapid development for the past 3 years. For instance, as you can see here, since the rollout of ChatGPT in 2022, almost every month you see new versions of language models. And I would like to just highlight what. Next, please. Thank you. So language models brings different types of potentials and opportunities, of course, from the upstream screening, triaging to the more tertiary level of diagnostic, even decision making and management plan. Next slide, please. Of course, earlier on, we also reported a few possibilities, including triaging, medical record documentation. Next slide, please. That said, these models, they are not perfect, they are not accurate. Next. And this is why we need robust evaluation and preferably in a standardized manner. One of the earlier ways to evaluate these models are in the form of accuracy. So we look at how correct they are, mainly in the form of, as I mentioned, accuracy score and macro F1 scores, but these are not perfect. Next, please. Next. What I would like to propose is a range of evaluation, ranging from knowledge evaluation, the reasoning, and how they perform when it comes to tackling clinical tasks. And lastly, this is the most important bit, how can they actually act as a useful tool in a conversational environment? And these are the matrix that I propose, not just looking beyond accuracy, but also looking at also so text generation matrix. So these go beyond accuracy. They look at semantic similarity, meaning the matching of the exact words, and also in terms of the meaning, how similar the meanings are. And of course, there's one new matrix called align score. These do not just look at matching of words, but factual alignment. And just an example, we published this work a few months ago in JAMA Ophthalmology. We looked at the reasoning and we compare reasoning models versus general reasoning models. And we do not just look at accuracy, but we also look at text generation matrix, looking at the BERT and BART scores. And this gives us additional insights on the performances of these models. As you can see here on the right, the text generation matrix do give us additional insights. So I've touched on how to evaluate in terms of accuracy and text generation matrix, but we do need human expert evaluations, and this is where the laborious manual evaluation comes in. It is
Yes, can you hear me?
not laborious, but it does provide additional insights, as you can see here. And I'll just wrap up with my last few slides. And I apologize for the lag. There's some technical issue there. And last but not least, just to highlight a human evaluation, what I propose will be to look at some of the common metrics, looking at completeness, readability, and safety, and utilizing human expert evaluation in the form of panel, preferably in a panel of 3, etc. Next, please. I apologize, I couldn't control my slides, but next, please. But the current gap in large language model evaluation, especially in ophthalmology, is that there's no standardized benchmark. Of course, different groups have published multiple papers, but different groups use different set of data sets. Some are most of them, some are open source QAs, some are from their own hospital data or closed source data, but there's no standardized benchmark. And for that reason, our recent work, we propose a standardized benchmark, and we call it BENLO, Benchmarking Large Language Models for Ophthalmology. And this benchmark looked at both clinical knowledge evaluation and reasoning, and we have curated 900 items for this evaluation. So this is quite a robust one, and this will soon be publicly available. This work is currently under review. As you can see here, we curated our data items from multiple sources. And of course, it's quite raw, and a lot of the answers may not be correct, and they do not come with clinical reasoning. And for that reason, we went through 4 rounds of clinical expert cleaning, as you can see here, with multiple rounds of cleaning, filtering, and adjudication. And lastly, we tested how good this benchmarking works by looking at a few models just as a test. And we looked at, as well I mentioned, accuracy, text generation matrix, and as well as human expert evaluation. So this is the way forward and to establish a standardized benchmarking for large language models in ophthalmology. And last but not least, as I mentioned, the holy grail will be to evaluate large language models in the form of clinical dialogue. But in the interest of time, I shall skip this. Next, please. So in summary, it's a very exciting field, advancing rapidly. But how to evaluate robustly, how to evaluate in a standardized manner, these are questions which are yet to be answered. And of course, I've just offered my 2 cents looking at this in a few aspects. For example, knowledge, clinical reasoning, clinical tasks, and lastly, conversational evaluation. Next, please. And with that, I shall end my talk and credit to my team again, and I'm happy to take questions at the end of this session. Apologize for the technical issues. Thank you.
No worries, Dr. Tam. Thank you for joining us from so far away. And we're going to definitely have some questions for you, I'm sure, during our next panel. And we're going to turn it over to Dr. Chen. She's going to talk about our traditional deep learning models as good as retinal specific foundational models for ocular and systemic diseases.
Thank you for having me here. So in the past 2 years, foundation model has changed the way we approach data and the way we train deep learning models. So compared to the traditional deep learning model, the major advantage of a foundation model is that it utilizes huge amount of unlabeled data for pre-training, and the model then can be fine-tuned with small data set for different downstream tasks. As we all know, large language models are actually one type of the foundation models. RedFound is the first image-based foundation model. It was trained using masked autoencoding, MACs, a self-supervised learning approach. The model was later fine-tuned to handle different clinical tasks. My research group also developed another retina image foundation model pre-trained with 38 million of synthetic fundus photo and OCT scans. The model can also be fine-tuned for downstream tasks. Nevertheless, there are remaining knowledge gaps. The comparative performance of RedFound and other traditional deep learning models is unclear. It's also unclear how this model performs when fine-tuned on a smaller dataset. Therefore, we compare the performance of traditional model and RedFound when fine-tuned on different number of retina images in detecting ocular and systemic disease. The traditional model we use are ResNet 50, VIT, base, and Swim V2s. These models are pre-trained through supervised learning on natural images, whereas RedFound uses a combination of natural and retinal image using masked autoencoders. These four models are then fine-tuned to detect four ocular diseases, including visual impairment, cataract, glaucoma, and diabetic retinopathies, and also three systemic diseases using one internal test set and multiple external test sets. To streamline the explanation, I will refer to training of the traditional model as fine-tuned in the following slide. So the main data set that we use for fine-tune and internal test is the Singapore Epidemiology of Eye Disease Study, which is a multi-age cohort with very detailed phenotypings. We first fine-tune the model using 100% of data and then evaluate on a fixed internal and external set. We repeat this process with progressively smaller data set. For visual impairment, the graph here shows the AUC across different models. When fine-tuned on full dataset, all models are comparables. And when fine-tuned on smaller dataset of 200 or 100 images, all models are again comparable across all models. Our external test further validates our result, showing largely comparable performance across all fine-tuned models. For cataract, the results are very similar, comparable performance across all models when fine-tuned on full dataset and also on small dataset. The external tests also show a very similar trend as well. For diabetic retinopathy, when fine-tuned on full data set, all models are comparable, and when fine-tuned on a smaller data set, we found that RedFound performed better than the traditional model, such as ResNet 50 and the VIT base. Our external results show similar trend. RedFound consistently performed better than ResNet 50 when fine-tuned on smaller dataset. For glaucoma, again, comparable performance is seen on all full dataset, and Refund performed better than ResNet 50 VAT based on smaller data set. And the external result again validate these observations. Now let's move on to the systemic disease. For diabetes, when fine-tuned on full data set, Refund performs better than ResNet 50 and VAT base. On smaller data set, Refund achieved highest performance across all models. Our external test result again show Refund perform largely the best at the smaller fine-tuned data set. So similar result for hypertension and external external test show Refund perform the best at a smaller fine-tuned data set. So similar trend we observe for the coronary kidney disease. Again, Refund achieved highest performance on small data set, both in the internal test set and also the external test set. So when comparing the resource required for fine-tune all four models in detecting visual impairments, Refund performed the highest. Actually, Refund requires the highest GPU memory and the longest times. So here is our key observations. For ocular disease, when fine-tuned on full dataset across all ocular disease tests, traditional models are as good as the Refund foundation models. However, when it comes to the systemic disease, when fine-tuned on a smaller dataset, Refund appear to be performing better than traditional models. And this is likely due to the foundation model's pre-training approach, which allow it to capture subtle retina-specific features which are associated with systemic disease. So in conclusion, selection of using either traditional model or foundation model depend on this four consideration: performance on the intended task, availability of data, the computational resource, and also generalizability considerations. So I would like to credit this work to the earlier speaker, Dr. Yizhong Tan. He actually did most of the work for this study, and also my collaborator, Dr. Yong Liu from A-Star in Singapore. And with that, I want to thank you for your attention.
Thank you, Dr. Chen. Really great presentation. Appreciate you coming in and logging in late in the evening in Singapore for us today as well. So we're going to turn over to Dr. Engelhardt. She's going to talk about she's one of our abstract winners. In fact, she's going to talk about the evolving patterns in VR surgery and analysis of Medicare Part B claims data from 2000 to 2022.
Hello, everyone. Good morning. Thank you so much for the opportunity to present today. These are our disclosures. Medicare spending, as we know, remains a key topic of national attention, and we see headlines like these in the news every day. And yet, as we can see here from the American Medical Association across all of medicine, from 2001 to 2025, although practice costs have inflated significantly, Medicare physician payments have declined 33%. And interestingly, in 2025, every other major player, hospitals, hospices, ASCs, have all received an update, everyone except for physicians. Understanding Medicare utilization and spending trends provides critical insights into the changing landscape of medicine, and for us, into the changing landscape of surgical retina practice. This was a retrospective cohort study analyzing 23 years of Medicare Part B claims data from the Centers for Medicare and Medicaid Services. We identified CPT codes of the most common surgical retina procedures. All dollar amounts discussed in this talk are inflation adjusted to the year 2000 US dollars using the Consumer Price Index. As we all know, the story of surgical retina has been one of technological advancement and innovation, but it's also been one of increasing demand and shrinking reimbursements. From 2000 to 2022, there's been a 42% increase in surgical retina claims volume and a 33% mean decrease in per case Medicare reimbursement. So we're going to look at some of the more common surgical retina codes. This is code 67036, pars plana vitrectomy. We see over the study period, there's been a significant increase in procedure volume and a decrease in inflation-adjusted reimbursements. This is PPV with PRP. We see a decline in procedure volume over time, and yet again, a decline in reimbursements. Moving on to membrane peeling surgeries. This is code 67038, PPV with ERM stripping. This code ended in 2007. We see from 2000 to 2007, there is a dramatic increase in procedure volume and a decline in reimbursements. In 2007, this code was split into 3 codes. We're going to focus on 67041 and 67042. This is 67041 PPV with removal of ERM. Procedure volumes have declined for this code over the study period, and this is the only code for which reimbursement has remained stable. Next, PPV with ILM peeling. Procedure volume has increased and reimbursement again has declined. Switching gears to retinal detachment surgeries. We see a dramatic decline over the study period in primary scleral buckling procedures, and again, declining reimbursements. For repair of retinal detachment via vitrectomy, 67108, we see an increase again in procedure volume and a decline in reimbursements. And finally, repair of complex retinal detachment, 67113, we see an increase yet again in procedure volume, and as you may have guessed by this point, a decline in inflation-adjusted reimbursements. When we look at retinal detachment repair technique as a proportion of total procedures performed, we see again declining primary scleral buckling procedures and the dominance of vitrectomy-based approaches. Although vitrectomy dominates across every US Census region, there are some regional variations. Scleral buckling is performed more frequently in the Midwest, and pneumatic retinopexy more commonly performed in the South compared to other regions. When we look at surgical assistant use, surgical assistant is defined as either a physician who is assisting or a nurse practitioner, physician assistant, skilled assistant. We see that use of assistants has declined across all codes over the study period. And when they are used, they're primarily used in the repair of retinal detachments via both vitrectomy and scleral buckling. Surgical assisting use varies by region with very infrequent use in the South. And when we look at ASC utilization, the data only allows for interpretation through 2007, but from 2000 to 2007, there was a more than doubling in the use of ASCs, and it's reasonable to expect that that trend has continued. And so I want to leave you with this. In the colored lines here are the surgical retina codes I discussed in this talk and some additional codes as well. And we see that reimbursements across the board have declined significantly over the study period, while inflation has dramatically increased. And this is important because when I made this talk, these were proposed cuts from CMS for 2026. These are now finalized. There's a 2.5% efficiency reduction that affects many of our surgical retina codes. And so in summary, volume is up and reimbursements are down. The demand for our services is rising and the case mix has become more complex, and yet real reimbursement per case has fallen across all codes, with additional Medicare payment cuts not now finalized. And so it's necessary that we as a community support evidence-based payment that reflects the complexity of what we do and preserves timely care. Thank you so much.
Thank you for that talk. It was sobering, Dr. Engelhardt, to see that data. So it's great to have, obviously, you investigating that and helping us bring light to that issue for our field. And we're going to bring everyone back on stage now for the question and answer period. We have a few minutes to talk about various topics and issues. And I'd love to talk about one aspect that many of you brought up in your discussion, which was the sometimes disconnect between documentation and ICD coding. And I'd just like to investigate that a little further. Are we really worried about this being a major issue, a minor issue, or something we need to solve for, I guess is the question. Maybe I'll turn over to Dr. Els, if you don't mind. I know you have some expertise in this area. Then I'd love to hear from anyone else who can talk about this as well.
Yep. I think where we see it most evidently is actually in the EPIC system, which is even more complicated because the EPIC system itself has a different disease encoding system than ICD. So we need complicated tables actually to translate the EPIC code to the ICD code if you would like to use it for research purposes. And on the top of that, often it is semantically different. Yeah, we have different EPIC codes translating to the same ICD code, and sometimes also the opposite way. I don't think there's an easy solution for that. But in some way, I mean, we need the ICD codes definitely for all kinds of research purposes because it's kind of the only commonly adopted standard we have. Yeah, so nobody uses the plain EPIC codes, although actually they are part of every single EPIC system. Okay.
Yeah, Josh, how about you? Dr. Stein, you've obviously dealt with this to some extent to integrate all these EPIC systems into one, and then you have to produce the end result. So
Yeah, I mean, I think the purpose of ICD codes is for billing and reimbursement, not for research purposes. And, I think that there are ways now that we're able to access more than just the billing codes to create these enhanced phenotypes where you can look at charges and orders and eye exam findings and come up with more robust ways to identify patients with different conditions. And we've done some work in this area where you can create phenotypes that are based on all different areas of the EHR. And my hope is that people will start, other researchers will start using these phenotypes, and that will get us better at making use of the data. I think that I'll stop there.
Rishi, I would add that
Mhm.
I don't have data on this, but using a highly specialized database like the Vestrum database, or where it really is dependent on retina subspecialty practices, I would suspect that the coding is probably more accurate as you get into a more and more specialized database, because the panel of codes is narrow in many of these practices, and they become expert at a fewer number of codes. Whereas if it's a hospital system with residents and fellows and a diverse mix of providers, you may have uh, increasing inaccuracy. I would think. Again, I don't have data to back it up, but just from my own experience, there's a tremendous emphasis in retina practices, to code accurately and be compliant.
Mhm. Dr. Y, with Trinetics, how are you encompassing this, or do you feel like it's an issue with some of the data you pointed out as one of the drawbacks of the analyses in Trinetics? But I wonder if they've helped or solved for that in any certain way.
Yeah, so I definitely agree. I think it is our largest limitation is relying on the accuracy of physician coding, but I do think there are some ways to get around that in order to essentially code smarter. For example, if we're looking at diabetic retinopathy codes, for example, making sure that the code is used more than once. So let's say the patient needs to have that ICD-10 coded 3 times and then also need a HbA1c that is at least over 6.5 at some point in their life, or they're on some medication. I do think there are kind of some ways to try and make the data a little more robust, but I certainly agree. I think that is a limitation, and it's something that we always should be cognizant about when interpreting the data ultimately.
Yeah. Dr. Rao, your talk was interesting for a lot of reasons about surgical retina, and I want to maybe have you and Dr. Engelhardt comment on some of the topics you brought up. I mean, I think you have a robust data set, but it seemed to me, at least from what I understood, was that there was a disconnect between truly the EMR data and sort of having the underlying diagnosis. Is that really a challenge for you? And then I'm going to ask a follow-up question, Dr. Engelhardt, after that about her data set, but I'd love to kind of hear if that's really an issue for this data you presented today.
Yeah, definitely. Rishi, I think the hard part is linking all this like surgical data and like during the time of surgery to be able to reflect what is actually happening. And I think linking that to practices and institutions and kind of getting a deep dive into their EMR would be helpful to be able to link the cause out, these surgical data as well as images, really. I think images tell a more complex story than just coding an EMR. So I think a better kind of solution and integration in the future is be able to correlate your surgical parameters to images pre-op and post-op, as well as the EMR and what people are saying.
Yeah. And Dr. Engelhardt, when you talk about your study, which was sobering to see all the data on, the changes, do you think that some of the coding parameters may have been affected by this, or do you really think that this is truly the base case scenario of it being proper, that everything you're seeing is what's really happening in the system?
I think for the surgical codes in CMS at least, I think coding may be less of an issue. I think the bigger limitation is that it's fee-for-service Medicare patients only. So no Medicare Advantage plans, no commercial insurers. You're only capturing a subset of the overall, patients who are having surgical retina procedures. And, certainly there can be some overlap in some of the codes, but I think it's more, we're seeing what's actually happening with this slice of patient.
Dr. Tam and Dr. Chen, I just wanted to ask you one last question before we move on to our next section. Thank you everyone for participating, and we have some more talk coming up. I think a lot of us are starting to use ambient listening in the clinic as a way of note taking. And I wonder, in the large language model discussion you had, Dr. Tam and certainly Dr. Chen, you might touch on this, or anyone else for that matter. Is that going to change some of the inputs or efficacy, or I should say efficiency, of what you're proposing and doing the work you're talking about doing? Because it would help, I think, in some ways of pinpointing the right patient, the right diagnosis. Can you talk a little bit about what ambient listening might do to our practices in that way?
Yeah, sure. Excellent question. And I think a few sites in US and in Singapore as well have started some pilots in that regard. I think in a few aspects, I think one is in history taking. That's the obvious one. Well, it really depends on the way to deploy it. If it's and what you want to capture. If it's some low risk task, it does help to save a lot of time and save a lot of typing time as well. But when it comes to consolidated information, of course, it's not perfect. There will be some errors. So how do you pass the human in the loop? That is something to be designed according to the situation and the scenario, and whether it's history taking for first visit or history taking for long-term follow-up. So these are the things to be considered as well. Of course, the more the follow-ups may be a little bit easier because there's already context and depends on how you design and set the language models to perform. So those are my 2 cents, but I think definitely one of the first areas where we can really deploy language models for clinical ophthalmology.
Great. Well, I want to thank you all for participating in today's program. It really is great to see so much wonderful sources of data, wonderful people investigating it. Couldn't have asked for a better group of people to take that on. Actually, this is a question from somebody else. Let's just take this last one. How about this one? This is for Dr. Stein. He's going to answer it offline. So perfect. Dr. Stein will take that one offline for us. Thank you. So we're going to turn over to our next part of the program for today. And I think I'm going to be turning this over to my colleague, Dr. Vanderbeek, who's going to be going through the next section.
Great. Well, that was a great session on
Oh,
intro to.
sorry, Dr. Durga. Sorry, I didn't see you there. My apologies. Thank you, Durga, for taking over.
Of course. That was a great session on intro to data sets and applied methods. Now we'll be focusing on some real world studies that are really looking at outcomes in retinal diseases. I'm Durga Borkar from the Duke Eye Center, and we'll be starting our session with Jordan Graff from Barnett Delaney Perkins Eye Center in Phoenix, Arizona. Thank you, Dr. Graff.
Thank you. Good morning, friends and colleagues around the nation. It's an honor to present on behalf of my co-authors here listed the real-world efficacy and safety of ranibizumab PDS in wet AMD. These are the 2.5-year results of the Summit study. This is the study design. You can see my disclosures. Next slide, please. This is the study design for the Summit study. This is a commercial PDS data collected from across multiple sites nationwide. Collected data, I think that's skipping around on the slides. Can we go to the next slide, please? Thank you. And the next slide. Thank you very much. So a total of 53 patients with a mean age of approximately 80 years of age, ranging from 59 to 91, with a majority of our patients being females at 66%, as you see here. Next slide. Here we can see the visual acuity measured over the course of the study so far at 2.5 years or 2 years of follow-up here. Baseline is the last visit prior to the PDS surgery, and day one is defined as the post-op day one, and days for follow-up averaged over all patients is approximately 9 days post-op, and then so forth for the rest of the visits, as you see across the graph. From baseline to day one, we see an expected drop in visual acuity due to the surgical procedure itself. And then, of course, visual acuity improves while healing following surgery and is stabilized between visits, follow-up 4 and 5. And as you can see, we find throughout the course of the visits, the visual acuity stabilized and is maintained over the course of the follow-up of the study. Next slide. As we follow the anatomical parameters over 2 years, we see that the CST is maintained stable over the course of the study duration. I'm getting a glitch on my screen here. I hope you're seeing the slide that I anticipate you being able to see. Of course, the CST should be, thank you, the CST should be very well controlled from pre-insertion injection treatments. And then even still, we do see some further improvement in the CST with implantation of continuous delivery with the port delivery system. Overall, the anatomic control is maintained over time. This highlights the durability, which we'll discuss a little bit more here in the next slide. Next slide, please. As part of the Summit study, the PDS demonstrated excellent durability with the mean refill exchange being at approximately 7.5 months between each procedure. Over the course of greater than 2 years, the time between refills remained fairly stable, as you see in the column there in the center. One patient did present with disease activity and was due for an anticipated refill exchange procedure in the clinic, but the site did not have the refill supply. And since the patient had disease activity, that patient did receive, as you see at the bottom, an aflibercept injection. Additionally, over the course of the study so far, we've had 2 patients receive faricimab injections between refills for disease activity, and making for about a 5% supplement injection rate. And this is consistent then with in the real world with the landmark large clinical trial data of about 95% of patients not receiving any supplementation. In the large clinical trials, the landmark trials, we are looking at being in 6-month refills, and here we're looking at 7.5-month refills. Next slide, please. A total of 53 patients had been followed in the Summit study and have demonstrated favorable safety outcomes with 0 cases of endophthalmitis, which was something we were watching for. Most adverse events were anticipated post-surgical, as you can see in the table, and have all resolved over time. Next slide. We're continuing to follow these 53 patients and are expecting our database to have even more patients over time. Longer-term data will be presented at additional trials and additional presentations going forward, but we are pleased to see what we are seeing in the real world, similar to what we've seen in landmark clinical trials to date, as we see here summarized. Thank you very much.
All right, great talk. Thank you, Dr. Graf. Next, we have Houri Esmail-Kanian from the Byers Eye Institute. Thanks for joining us.
Good morning, everyone. My name is Houri, and Today, I'm going to talk about intraocular pressure following combined intravitreal anti-VEGF and anti-complement injection in AMD from real-world data. Oh, I'm sorry. Okay. I have no disclosure. So anti-VEGFs, we all know that are the backbone of treatment for neovascular AMD, and anti-complement since last year were approved for geographic atrophy, and clinicians are increasingly used both for treatment of AMD. However, in some studies, including like a pivotal trial for avacincaptad, it has been shown that 9% of patients developed increased IOP. However, it was like less than 1% in sham, and it was immediately post-injection. It was transient, and it resolved on the same day. And also for anti-VEGFs, we have a meta-analysis that showed that following anti-VEGF, we had increased risk of sustained IOP with a summary risk ratio of 3, and it was correlated with follow-up duration of from 2.14 at 6 months to 3.48 at 23 months. So these data raise a critical question. What happens if we use combined anti-VEGF and anti-complement injection in AMD patients? And this is the aim of our study, that if it increased the IOP following intravitreal injection. So we designed a retrospective study including 52,649 patients, representing around 55,000 eyes, and more than 1.1 million injections were administered across 20 centers of Retina Consultants of America. We stratified the patients into two main cohorts of monotherapy versus dual therapy, and further stratified monotherapy to anti-VEGF monotherapy and anti-complement monotherapy. And for dual therapies, we stratified the patients with anti-VEGF, anti-complement dual therapy, meaning that these patient cohorts first received anti-VEGF, and then throughout their disease course, they also received anti-complement or anti-complement anti-VEGF dual therapy, meaning that they first received anti-complement and then anti-VEGF. And what we observed was that at baseline, there were no statistically significant difference between IOP in the total cohort. As you can see here, it ranged from 13.90 to 15.16, and in the from baseline to 6 months, they had some changes in IOP. However, it was not statistically significant in most of them, unless anti-VEGF, anti-complement dual therapy. However, it was increased in IOP, not an increase. And from baseline to last visit, we had still statistical difference in most of them, anti-VEGF, anti-complement dual therapy, anti-complement anti-VEGF dual therapy, and anti-VEGF monotherapy. However, still it was not an increase in IOP. And here is the overall visuals for that, demonstrating that the IOP was stable throughout the study. However, we have some significant, changes in some of the cohorts, but it was because of the decreasing number of patients throughout the follow-up periods. So in conclusion, combined anti-VEGF and anti-complement intravitreal therapy do not increase IOP permanently. In the next step, we want to further stratify patients with simultaneous injection versus subsequent injection for these two medication and see if there is any difference between them regarding IOP. And thank you. I would be happy to take any questions or.
Great, thank you. And we'll have some questions at the end. So up next, we'll have Deepak Sambara from Eye Clinic of Wisconsin.
Hey, thanks for having me, guys. My name is Deepak Sambara. I'm a partner and the medical director of research at the Eye Clinic of Wisconsin. On behalf of my co-authors, Nick Boucher and Rusarini Fernando, part of the Vestrum Health Database, it's my privilege to be here at the Real World Data Summit. Just hearing some riveting presentations and just glad to be here on a Saturday. I have the chance to present real-world intraocular pressure and glaucoma outcomes from intravitreal treatments based on injection volume. And here are my financial disclosures. So we know that traditional intravitreal therapies are administered in fixed volumes of 50 microliters. In 2023, a wave of new medications gained FDA approval, including aflibercept 8 milligrams for the treatment of neovascular AMD, diabetic retinopathy, DR, and diabetic macular edema, DME, pegcetacoplan or PEG, and avacincaptad pegol or ACP for the treatment of geographic atrophy secondary to macular degeneration. Now, all of these medications involve higher volumes of administration, ranging from 70 microliters in the case of aflibercept 8 milligrams to 100 microliters for PEG and ACP. And despite great phase 3 robust clinical trial data that suggested there wasn't an appreciably higher risk of IOP elevation or glaucoma with any of these meds in their registrational trials relative to their control groups, the real-world evidence on this subject is still lacking. And that's the exact motivation behind this study. This is an observational, retrospective, comparative study using the Vestrum Health database to assess IOP outcomes and the development of glaucoma in treatment-naive eyes started on intravitreal medications based on injection volume. Our total population of eyes started with over 1 million eyes. Eyes were censored based on the criteria here, including any history of ocular trauma, ocular or systemic steroid use, switching from the index drug or receiving a different drug concurrently, or discontinuation of treatment defined as greater than a 6-month gap in care. A matched analysis was performed where eyes were matched 1-to-1 or 1-to-2 against a control group receiving intravitreal therapies of standard 50 microliter volumes. Eyes were matched across diagnosis, baseline age, baseline IOP, number of injections in the follow-up period, and the total follow-up period. A Cox proportional hazards model was used to assess for the risk of adverse events. Now, it's important to note in the data set here, we're only looking at treatment-naive eyes that do not have any history of glaucoma or any pre-existing risk factors for the development of glaucoma. So we were looking at eyes, tabula rasa, no risks for developing glaucoma, do these higher volume meds, put you at any higher risk of developing glaucoma than 50 microliter preps. And so this was the demographics of our study group. You can see here that the mean IOP was around 14 millimeters of mercury across all index drugs and their control groups. Now, in order to control for serial treatments over time, which is particularly interesting with anti-VEGF therapies where many patients are treated via a treat and extend paradigm, the mean number of days between treatments were tracked and mapped over time, both for the index drugs and their control groups. And what you can see here is that this appeared to be pretty similar across all drugs and their controls, with the exception of aflibercept 8 milligrams, the sole anti-VEGF agent being analyzed. You can see that the mean number of days between treatments increased over time, but that also was seen in their control group. So when you look at the results of the risk of IOP elevation over time, we didn't find any statistically significant differences between any of the index drugs and their controls. In fact, IOP consistently remained within a millimeter of mercury within each other for the index drugs and their control groups. Now, you can also look at this on a per injection basis. Does subsequent injections of these higher volume medications increase your risk of IOP elevation relative to the control groups? And we did not find that for any of the 3 medicines relative to their controls. We did a Cox proportional hazards model to look at the risk of IOP elevation from baseline, and we wanted to look at the risk of a greater than 5 millimeter elevation of IOP from baseline. And we did see a signal here specifically and uniquely to pegcetacoplan. There was a greater risk for IOP elevation of 5 millimeters from baseline relative to the control group only in the PEG group. Now, to be fair, PEG had a higher number of larger number of eyes in the data set and a higher longer runway for follow-up. So they had a longer follow-up period. But when you're kind of looking at it clinically, the risk of significant IOP elevation defined as a single visit at any time point where IOP was measured at greater than or equal to 25 millimeters of mercury, we didn't see any signal between any of these meds and their control groups. And finally, when assessing for the risk of glaucoma, this would be based on ICD-9 or ICD-10 diagnoses in the EHR. There were no increased risks of glaucoma in these higher volume medicines relative to their 50 microliter control arms. So in conclusion, this is a large real-world data set that suggests that there's no increased risk in the development of ocular hypertension or glaucoma with the use of newer higher volume intravitreal agents compared to other intravitreal therapies of 50 microliter preps. However, PEG did show that increased risk of IOP elevation greater than 5 millimeters of mercury compared to their control arm. As newer intravitreal agents with higher volumetric doses continue to be ushered into our clinics, it's going to be absolutely crucial for us to track and map these patients over time to know what the true risk of glaucoma is. I think the next step for this data set is to just rerun and re-interrogate the Vestrum Health data set, but this time looking at patients who have a pre-existing diagnosis of glaucoma and seeing whether these patients are at risk for glaucomatous progression. I want to thank you guys for your time, and I'm really looking forward to the next set of speakers. Thank you.
Great. Thanks for a great talk, Deepak. Our next speaker is Rahul Khurana from Northern California Retina Vitreous Associates.
Good morning. I'm excited to talk to you today about outcomes of patients with proliferative diabetic retinopathy treated with anti-VEGF therapy and or PRP in the United States. Maybe we'll go to next slide. Here are my financial disclosures, the only ones that are relevant, that this was supported by a Hoskins Center IRIS Registry Research Award. So Protocol S really brought us a new treatment option with anti-VEGF for treating proliferative diabetic retinopathy. However, compliance really can't affect our treatment decisions. I think case series came out with poorer outcomes of patients treated with anti-VEGF therapy for PDR. I think the thing that we always worry about in our clinic, you have a patient who comes in with PDR, you give them 1 to 2 injections of anti-VEGF, they never follow back up, and they return a year later with a tractional retinal detachment. Now, previous studies had shown loss to follow-up rates as high as 50% in individual centers. We did work looking at the American Academy's IRIS registry, where we found loss to follow-up rates about 10 to 12%. And just to kind of review some of this previous work that we looked at, this was published in Ophthalmology Retina, and we looked at the American Academy's IRIS registry, which is the largest ophthalmic registry in the United States involving over 90 million patients. We looked at patients who were newly treated or diagnosed with PDR between January of 2013 and December of 2015, and subsequently treated with either anti-VEGF therapy, PRP, or a combination approach. We defined loss to follow-up as a visit of greater than 12 months from last treatment from either intravitreal injection or PRP. And what did we find? The data set, we looked at over 353,000 patients who were newly diagnosed. We excluded other patients who may have received anti-VEGF therapy for other causes, and that essentially left us with a data set of about 74,000 patients who were newly diagnosed with PDR and subsequently treated with anti-VEGF therapy, PRP, or combination. And essentially, what did we find? We found that about 12% or 1 in 8 patients subsequently were lost to follow-up. And among that 12%, about 31% had later follow-up. And the purpose of this talk was essentially to look at the set of patients who were lost to follow-up. Now, the previous study showed rates of about 10 to 12% in this national registry that were present for each of the combination therapies that were shown below. So we wanted to look at the next step. Well, how did these patients do who were lost to follow-up who subsequently came back? So as you recall from the previous study, we had about 73,000 patients that we looked at. About 8,000 of these patients were lost to follow-up, but 31% of these eventually did come back a year later, and we could see how these patients did. And when we looked at the outcomes, you can see that their visual acuity before they got lost to follow-up was about 20/50. And when they came back after over a year, their vision dropped to 20/60. But once they got retreated, their vision actually returned to baseline. So that was quite reassuring. We also ran a multivariable regression model where we looked at a poor visual outcome. That was a visual outcome of worse than 2,200 12 months after being lost to follow-up. And what we found here was that patients treated with anti-VEGF therapy alone had a nearly threefold higher chance of having a poor visual outcome in comparison to PRP. We also found that women had a nearly threefold higher chance of having a poor visual outcome in comparison to men. We also looked at new complications, and it's not surprising that when patients came back after being lost to follow-up, they had a higher rate of complications from PDR. 14% developed diabetic macular edema, 8% developed vitreous hemorrhage, 3% developed tractional retinal detachments, and 1% developed neovascular glaucoma. But were there any differences among the three treatment modalities? And you can see actually when we saw that in the diabetic macular edema group, that there were more patients, nearly 28% of patients in the anti-VEGF monotherapy arm developed DME, 20% in the combination arm versus only 10% in the PRP monotherapy arm. And this was also statistically significant. There were no difference in the rates of new vitreous hemorrhage and tractional retinal detachment, and there were higher rates of neovascular glaucoma, although the rates were very small at 2.4%. We then ran a multivariable regression analysis looking at the development of new complications within 1 month of returning after being lost to follow-up. And here you can see that both anti-VEGF therapy alone and both combination therapy alone had a higher rate of developing new complications in relation to PRP alone. We also saw that the length of lost to follow-up duration, the longer that you were lost to follow-up, you had a higher chance of developing complications within 1 month of being following up. So in summary, patients who are lost to follow-up develop serious vision-threatening complications and are at risk for vision loss. Both anti-VEGF therapy and combination of PRP and anti-VEGF are at a higher risk of complications and worse visual acuity when they return after being lost to follow-up in comparison to PRP initially. And compliance concerns and complications may favor PRP treatment options. This work is now available online in Ophthalmology Retina. Thank you for your time.
Great talk. Thank you, Rahul. Our next speaker is Michael Javahari from Retina Specialists of Beverly Hills.
Hi, it's great to be here with such great friends and to follow one great friend and to see a bunch of great colleagues and to speak on 8 milligram of aflibercept in our real world study. Here are my disclosures. I'd like to thank my co-authors. As we all know, in the Photon trial, aflibercept 8 milligram with extended dosing achieved similar visual acuity outcomes with fewer injections compared with aflibercept 2 milligram through 96 weeks in patients with DME. But how does that translate to treating patients with DME in the real world? A lot of us do things a little differently than monthly or every other month dosing. And this study, by looking at real world data, can tell us what are the treatment patterns in patients with DME who were previously treated with other anti-VEGF agents before switching to 8 milligram of aflibercept. Our study design looked at patients in the IRIS and Vestrum databases that received an index injection of aflibercept 8 milligram. They were narrowed down based on the following eligibility criteria, with the most important being that they were consistently treated with an anti-VEGF agent in the pre-dosing phase, prior to the pre-dosing phase injection. Well, when we looked at the patient characteristics, what did we see? They were predominantly male. They had a vast predominance to bilateral DME, and approximately 1/3 of the patients had the fellow eye treated with 8 milligram of aflibercept also at the index date. In the IRIS and Vestrum databases, respectively, the duration of post-switch follow-up days was 194 days and 304 days. The number of 8 milligram injections during the follow-up for the IRIS database was 3, and for the Vestrum database was 4.3. As we can see here, the vast majority of patients that were switched to 8 milligram aflibercept were switched from 2 milligram aflibercept. In eyes with an average pre-switch injection interval of 4 to less than 6 weeks, we saw an injection interval extension of 3 to 4 weeks after switching to 8 milligram aflibercept. In eyes with an average pre-switch injection interval of greater than or equal to 6 to 8 weeks, we saw an injection interval extension of 2 to 3 weeks after switching to 8 milligram aflibercept. The study was based on data from electronic medical records, which may not reflect our full patient's medical history, including treatment history. Another limitation would be a subset of patients who had at least 2 injections prior to switching to 8 milligram aflibercept from other therapies were included in this analysis. And also, this analysis represents early real-world experience with aflibercept 8 milligram and has had a limited follow-up period. In conclusion, most eyes switch from aflibercept 2 milligram prior to initiating 8 milligram aflibercept treatment. Eyes switching to 8 milligram aflibercept after consistent treatment with a previous anti-VEGF agent had an average injection interval extension of 3 to 4 weeks, and eyes with a pre-switch injection interval of 4 to less than 6 weeks, and 2 to 3 weeks for eyes with an average pre-switch injection interval of greater than or equal to 6 to 8 weeks. Obviously, additional analysis with longer-term follow-up are ongoing to assess the real-world durability and outcomes of 8 milligram aflibercept in eyes that were previously treated for DME. Thank you again for having me.
Great talk. Thank you. Next, we have Nitish Mehta from NYU Langone Health.
Okay, good morning, everybody. My name is Nitish Mehta, and on behalf of my co-authors, I am pleased to present the insights from early real-world use of aflibercept 8 milligram in eyes with neovascular AMD. So very similar to the previous talk, just a different disease state here. The disclosures are the same from the previous talk as well. Okay, so here we're going to talk about both naive and switch patients in these IRIS and Vestrum databases and the context of neovascular AMD. So we know that the PULSAR trial informed us that patients treated with 8 milligrams aflibercept were able to achieve similar visual acuity gains with fewer injections through week 96. And this is compared to aflibercept 2 milligrams dosed at every 8 weeks after that initial loading period. So to create this cohort, we were looking for treatment-naive patients, and they needed at least 1 injection to get included from summer of 2023 to summer of 2024. They were then followed until last visit in the system, until they were switched to a different medication, or if they had missing information, whichever one was first. And the data was available until the end of 2024 in the IRIS cohort and January 31st, 2025 in the Vestrum cohort. To be included into the injection interval analysis, you'd have to have at least greater than 2 injections in the loading phase, which essentially was that first 90 days, and then greater than 1 injection in the post-loading phase to be included in the treatment interval analysis. To be included in the visual acuity change analysis, as that's a very important metric as well, there was a subset of patients that had vision available at index and at least 90 days post-index date. So those were also assessed for visual acuity change. And then further, that cohort was then subdivided by index date vision using the 65 ETDRS letter or the 20/50 vision cutoff. So you can see here well-matched cohorts. These were, in contrast to the previous data set, mostly female, mostly older, mostly white patients, although the Vestrum database does not have demographic data. A minority of these patients had bilateral disease, and the visions were moderately poor. Here you can see that index date vision around 54, 53 letters. They were followed for an average around 5 months in the iris cohort and around 6 months in the Vestrum cohort. And you can see here during that time period, they received a mean of 3.5 injections in iris and 4.2 injections in Vestrum during that time. The N here reflects the patients who were eligible for that injection interval analysis. In the initial dosing phase, these are naive patients. They had a mean interval around 38 days. And you can see here that was similar between the two beta databases, and they both had an increase to 70 in iris and 67 days in the post-initial dosing phase here. And you can see the ends underneath the bar graph as well. When we look at mean change in VA for the smaller subset that actually had good visual acuity data, you can see that the patients that started with poorer vision at that 20/50 cutoff did show a visual acuity gain in mean, and versus the iris data set, versus the poorer vision data, if they had better vision, they remained essentially stable. This is the proportion of eyes with a greater than 5 ETDRS letter gain. If you started out with poor vision, you were more likely to gain 5, whereas if you started with better vision, you had a lesser proportion of those that gained. So now we wanted to switch and look at patients who had switch analysis. Here you have patients that were consistently treated pre-switch with an average interval around 4 to 8 weeks. Thus, these are patients that generally had frequent dosing requirements. And we were also curious to see how the injection interval changed post-switch, if in that pre-switch time they were injected more frequently, around 4 to 6 weeks, or if they're injected a little less frequently, around 6 to 8 weeks. And you can see here, similarly, they were followed for around 5 to 6 months, with closer to 6 months in the Vestrum database, well balanced. About half had bilateral disease. Cohorts that had index date vision between 60 and 70 letters. In both cohorts, in both cohorts, the eyes were mostly switched from 2 milligram of aflibercept. You can see here that the mean interval follow-up date increased between pre-switch and post-initial dosing phase. This is for patients who are more frequently injected in the pre-switch time, around 4 to 6 weeks, where they went from around 37 days between injections to around 57. And in those who came in injected a little bit less frequently, between 6 to 8 weeks, you can see here that the gain was less meaningful, but still appreciable, and as obviously they were injected less frequently to start with. So you can see here similar conclusions to the previous talk, whereas this one also included naive patients where you had visual acuity gains, you had increased intervals after the post-initial dosing period, and then switch patients, they also had increased dosing intervals. And as the limitations have been discussed previously, this is EHR data, limited time frame, and we're looking forward to see this data mature over time and report more outcomes. So thank you very much for your time.
Great talk. Thank you, Nitish. Next, we have Ted Lang from Bayer's Eye Institute.
Good morning, everyone. It's a pleasure to be here with you all. These are my disclosures. Of note, I have consulted for Genentech Roche, who is a sponsor of this study. Faricimab is the first intravitreal bispecific antibody that targets both Ang2, and VEGF-A. In the pivotal phase 3 trials, we have demonstrated efficacy, safety, and durability of this agent in neovascular AMD, DME, and RVO. Over 10 million doses have been distributed so far in over 100 countries, and it's been used in the United States since 2022. The wide adoption of faricimab provides ample opportunities for study of this agent in real-world patient populations. The FAR-RETINA study is a retrospective real-world study of faricimab with data from the American Academy of Ophthalmology's IRIS registry, comprising data from over 805 million clinic visits contributed by over 15,000 clinicians and 16 EMRs. The inclusion criteria is shown here, and in this cohort we'll be talking about today, the patient study had at least 2 years of follow-up data. We had a subgroup of patients with CST measurements as well for anatomic analysis for changes during that 2 years of follow-up. The faricimab neovascular AMD 24-month cohort included 5,728 patients and 6,799 eyes, a vast majority of which had received a prior anti-VEGF agent. The patient baseline characteristics and demographics were largely as expected in this population. In both treatment-naive and previously treated eyes, median visual acuity was maintained at 70 ETDRS letters from baseline to 2 years. This differs from prior studies of anti-VEGF, which showed a decline in visual acuity after 2 years of treatment. Anatomic improvements were also noted in the CST subgroup. It was lower at 2 years than baseline in both treatment-naive and previously treated eyes. Please note that these patients started faricimab with a lower mean CST at baseline than faricimab-treated patients in the Tenaya and Lucerne clinical trials, who had a mean baseline CST of about 357 microns. We also saw a reduction in the number of faricimab injections after the first 6 months of treatment, which continued into the second year of treatment. This is in line with the Tenaya and Lucerne results, where a mean number of faricimab injections was 7 in year 1 at week 56 and about 4 in year 2 from week 60 to 108. Lastly, the rates of intraocular inflammation and endophthalmitis per injection were also investigated in the overall FAR-RETINA AMD and DME population. The rates were low for both AEs, and they did not exceed those previously observed in the phase 3 clinical trials. So to summarize, visual acuity was stable and CST reduced over time in patients with neovascular AMD who received faricimab for 2 years. The injection frequency was reduced over the first year of treatment, which was sustained into the second year of treatment. Endophthalmitis and IOI rates were low and consistent with those seen in the phase 3 trials, and these findings support the real-world effectiveness, durability, and safety of faricimab for the treatment of neovascular AMD in the US. Thank you.
Great. Thank you, Ted. Next, we have Farhina Ali from Advanced Eye Physician Services.
Good morning. Thanks, Durga, and thank you for the invitation to present this work. Here are our group's financial disclosures. All right, so similar as just was presented in AMD, clinical trial results have demonstrated the efficacy of faricimab for the treatment of center-involving diabetic macular edema through the Yosemite and Rhine phase 3 trials, as you can see laid out here. Patients, as we all recall, were randomized equally into faricimab every 8 weeks after 6 monthly doses, faricimab PTI regimen after 4 monthly doses, and aflibercept 2 milligrams as on-label every 8 weeks. And so for that PTI dosing interval, adjusted every 4 to up to 16 weeks based on BCVA and CST criteria at active dosing visits, initially monthly, until achieving 325 microns at or after 12 weeks. And so what was found is that over 2 years, the faricimab arm showed similar improvements in vision and greater improvements in anatomy compared to aflibercept, and the safety profile was reassuring. In the treat and extend arm, in terms of really looking at that durability question, there were more than 60% on Q16 week dosing at year 2, and almost 80% on Q12 week dosing or longer. And the majority of these did achieve Q12 and Q16 at year 1, and that was maintained to extended intervals through year 2. And so here we wanted to investigate real-world efficacy amongst patients who received the label-approved loading doses of 4 doses before extending treatment within the subpopulation of the far retina study cohort who were treatment consistent with the label. So important to know really upfront, the real world populations are more heterogeneous. There is a lack of long-term data in the clinical trials. Replicating these protocols in the real world is challenging. And there's, of course, variability in provider treatment approaches, including in terms of the preference whether or not to load patients in the real world. So this is a retrospective study. We use the IRIS registry. It's already been well described today. The inclusion criteria is, as you see here, with the cohort having at least 2 years of follow-up, and there are known limitations to these data sets as are outlined below. In terms of key outcomes investigated here, we looked at median visual acuity at baseline as well as 24 months, the proportion of eyes with 20/40 vision or better, number of injections during that 24-month follow-up period, and of course, safety in terms of the incidence of endophthalmitis and intraocular inflammation. So here you can see the attrition table in total of over 5,700 eyes with 2 years of follow-up data, 589 patients and 725 eyes received on-label loading, the majority having been previously treated. These are the baseline demographics as expected for DME patients in this cohort. Now, what did we find? So in terms of vision, the median vision increased amongst those treatment-naive eyes over the 2 years with a median gain of 1 line. The median visual acuity remained stable in those eyes that had been previously treated. Now, the proportion of eyes with 20/40 or better vision increased for both treatment-naive and previously treated eyes at the end of the 2-year period. We next looked at durability in terms of the number of faricimab injections received in 6-month periods of the 2-year follow-up. And so the number of injections declined after the first 6 months of treatment, with the decline continuing into the 2nd year of treatment for both treatment-naive as well as the previously treated eyes. And importantly, the injection numbers were similar to those that were observed in the pooled Yosemite and Run trial population, with approximately 9 injections in year 1 and 4 in year 2. Here you can see, let's just go back to that slide. In terms of the safety that was seen in our cohort, the rates of IOI and endophthalmitis per injection were low for both of these adverse events and didn't exceed those that were previously observed in the clinical trials. So in total, in summary, this real-world cohort of on-label treated patients for diabetic macular edema, we saw visual acuity improvement in treatment-naive and previously treated eyes after 2 years of treatment with faricimab. The number of faricimab injections decreased after that first 6 months of treatment, suggesting an extension of treatment intervals. In year 1, that continued into year 2 of treatment. IOI and endophthalmitis rates were low and consistent with rates observed in phase 3 faricimab trials. And in total, far retina does demonstrate real-world effectiveness, durability, and safety of faricimab for the treatment of DME in the US. And this is another opportunity here looking at the on-label sort of cohort and really understanding the validity as compared to the clinical trials. Thank you for your attention, and I'll look forward to the discussion.
Great. Thank you, Farina. Next, we have Sam Miniker from Tyler Retina Consultants.
Thank you. Good morning, everyone. I'll discuss surgical outcomes of rhegmatogenous retinal detachment and fellow eye involvement in adolescent and young adult patients using a large database of retina specialists. And this utilizes the Vestrum Health database. Here are my disclosures. Retinal detachment occurs in young adolescent patients and young adults rarely but with regularity. And there's a strong preference for scleral buckle in this age group based on PVD and lens status. Although there are studies looking at retinal detachment in pediatric patients, there's more limited data on this young adult and adolescent group. Many of these patients are phakic without a PVD, and there are a limited series of patients in this group with limited follow-up. And some of the previous initial case series demonstrated a much lower single surgery anatomical success rate than would be expected, with much higher overall rates of PVR. And there was a focus on operative eye, but not looking at fellow eye, as we know these patients are at significant risk in their fellow eye as time goes on. We previously published the largest case series looking at this group and found that there was a strong preference for scleral buckle, but found that there were similar visual outcomes between the different surgical techniques in terms of straight buckle, vid buckle, and more rarely vitrectomy. We also found that with a 5-year follow-up, there was almost a 20% risk of the fellow eye developing a retinal tear, retinal detachment. This prompted us to do a retrospective cohort study utilizing the Vestrum Health database. And this study looks at patients between 2 years and 30 years who underwent rhegmatogenous retinal detachment repair within 30 days of a diagnosis and had a minimum of 3 months of follow-up. These patients were seen between January 1st, 2015 and June 30th, 2024. And patients were excluded if they had any history of proliferative diabetic retinopathy, uveitis, ocular cancer, prior retinal surgery, ROP, and connective tissue diseases, including Stickler syndrome. And these were identified using ICD codes. A total of 2,277 eyes were included, with a mean age being 22 years. The macula was attached in 63% of eyes, and scleral buckle was performed in 44% of eyes. Vit buckle was performed in about 10% of patients, and vitrectomy alone was performed in about 41% of eyes. 297 eyes had preoperative PVR, and in those patients, 21% of those patients underwent vit buckle, with only 12% of patients undergoing straight buckle or vitrectomy. 277 eyes had a PVD at the time of diagnosis, and there was a preference for vitrectomy, with 15% of patients undergoing vitrectomy, 10% of patients undergoing vit buckle, and 9% of patients undergoing straight buckle. 185 eyes had vitreous hemorrhage at the time of diagnosis, and there was a preference for vit buckle and vitrectomy, with about 12% of patients undergoing those procedures and about 5% undergoing straight buckle. The presence of lattice degeneration, choroidal detachment, history of trauma did not appear to favor one particular technique. The single surgery anatomical success rate was 86% for straight buckle, 84% for vit buckle, and 79% for vitrectomy. The mean final postoperative ETDRS change was 26.9 letters, 27.9 for straight buckle, 31.8 for vitrectomy, but only 9.5 for vit buckle. However, we speculate this may be due to lens status or a slightly increased risk of PVR. The postoperative PVR rates were 9% for scleral buckle and then 13% for vit buckle or straight vitrectomy. 105 patients had bilateral surgery. 74 of these were diagnosed right away on the same date, with 50 patients being treated bilaterally on the same day. There were 55 total patients that were treated on different days, with a mean time to surgery of 207 days. This included both the patients that were diagnosed on the same day as well as patients that were diagnosed afterwards. In conclusion, scleral buckle alone was the most common surgical intervention. Outcomes are generally favorable for both straight buckle and vit buckle, and surgeons and patients need to be aware of the risk of bilateral retinal detachment, as well as the risk of subsequent retinal tear detachment in these patients. Future work will be looking at other postoperative complications, as well as other initial demographics in these groups? Thank you.
Great talks. If all the speakers could come on for a panel discussion, that would be great. And I'll add for the audience, if anyone has questions, please feel free to put them in the chat. Otherwise, I'll ask all of you all some questions. And I apologize if I don't get to everyone. I know we have only about 10 minutes. But Sam, I'll start with you since you just gave your talk. I thought that was a really interesting study. There were a couple of findings that I was a little bit surprised by with the average age of 22. It's just surprising that so many patients had vitrectomy alone. Do you have a sense of why that might be, given the population?
It's a little bit unclear. These patients were excluded if they had previous surgery. So these, I don't think, were patients that had a previous buckle. There was a higher rate of, cases of PVR or vitreous hemorrhage, and we're looking to see if there was trauma or other factors that may have caused those patients to have a higher rate of vitrectomy. But I agree, much higher than I would expect.
Thanks. And Ted, I think you presented some really compelling data looking at 2-year outcomes for AMD patients using faricimab. Obviously, we never quite see what we saw in the clinical trials when we look at some of these real world studies. In particular, like there's some differences in visual acuity gains. Do you have a sense of whether there were some key differences in baseline characteristics in far retina AMD compared to what we saw, say, in Tenaya and Lucerne that might help explain that?
No, we didn't see much differences in the baseline characteristics, however, except for the fact that their retinas were not as swollen on entry into the far retina as they were in the pivotal trial. So I think that could account for a little bit of a ceiling effect that we're seeing. But we also know that real world patients are not study patients, and over 50% of patients that are treated with any of these agents that are approved would not have qualified for any of the phase 3 trials that we conduct routinely in retina.
Yeah, that's a great point, and I think something to keep in mind when we're thinking about the results of these real world studies. Nitish, you presented some really compelling data from Vestrum and Iris for aflibercept 8 milligrams. And I think what was great about both your and Michael's studies is that you looked at this data in 2 different data sets. Were there any key differences that you found? For the most part, it seemed like results were fairly similar between the 2 data sets.
Yeah, I think the only major difference was lack of demographic data in Vestrum in what we were able to report. But the baselines were pretty similar and the outcomes were pretty similar. So I think this model should be continued. It's always good to report more than one data set. And in the previous session, we saw how there's a little bit flavors to it. I thought was also interesting about the way this team has put this together is putting the questions out in a way that make relevant sense from a clinical standpoint. It's like, well, what if the patient had good vision? What do I do if I switch them? What if they had poor vision? Or what if they were treated frequently before versus less frequently before? And all of it tends to give me confidence on the durability in terms of the visual acuity. Um, Obviously, incredible results, but I think that's where the magic is happening here in these real world data sets. But we definitely need more follow up. So we're excited to share in the future.
Great. And Michael, anything to add? And I think also just a follow-up question. Do you all have a sense of what overlap there is between the 2 registries in terms of, like, obviously there's some patients that are in both of these analyses?
With regard to overlap, no, I don't have any extra information on that. I'm sure, I agree with you. I'm sure there are some that overlap, but we're seeing the same kind of data anyway, so there's nothing odd, I think, that we're seeing with any of this. I think as we get further down the line, they may break apart some of that data and help us kind of see more into these databases, and that's what they're looking to do. I agree with everything Nitesh said. It's great to have this. It's great to see that people are doing just as well with less injections, and they're getting better as time goes on with these better agents that allow us to see them less and get them to the same place as we would have been treating them all the time.
Great. Well, thanks for those insights. Deepak, I think, your study looked at a question that we're all sort of wondering about as we have these newer agents that are higher volume. Are you able to look at whether any of these patients were put on IOP medications? Like specifically, does Vestrum have claims data that would look at that? I know you looked at ICD codes for glaucoma diagnoses, but when you show the graph of the change in IOP, do you know if someone was put on, say, timolol, for example, in between visits?
For sure. So that's a great question. I don't have it in this presentation, but we have a manuscript prepared with that data available. So there are a proportion of patients who had to start IOP lowering drops, during that follow-up period. I think the other thing to kind of keep in mind is with real world data, a lot of it gets messy in terms of, how you check vision, but also how you check pressure, right? So the other thing that I didn't have a chance to throw in there was the method of, pressure determination, whether it was applanation or tonal pen or eye care, because sometimes these measurements can be all over the place. And so I think that that is a very good point, that whether or not somebody is on drops makes a difference. And I think with this population that I presented specifically, because these are people that don't have a predisposition to IOP events or glaucoma, just based on how we selected and censored for subjects to include. But as you repeat the same set of circumstances and the same analysis with people who already have glaucoma, it would be interesting to see, hey, are these higher volume meds actually worsening glaucoma or leading to additional therapies or interventions?
And where in Vestrum do you get that IOP medication data? Is it linked to claims, or is it just something you would look for in the encounter if they
Yeah, so
code?
it would be in the encounter under the medications that patients are on. And so we would be able to track new medications as they were added over time.
I see, but not necessarily the person who prescribed them, like the
Correct. That would be a little more difficult to figure out who started the drop.
great. And Rahul, I really enjoyed your study. I was part of the Will study that looked at outcomes. It was obviously much smaller than what you presented. Did you find any differences from your initial paper between those who were just lost to follow-up completely and then those who did come back that were included in this analysis you presented today?
Yeah, so I think one of the challenges with any follow-up study is that patients who never come back, you lose those. And so any study we do, any real world, regardless for this or for anything that you see, you don't know what you're missing. And so we did look at the 69% of patients who never came back, and we looked at their demographics. And unfortunately, they did a lot worse. They had worse visual acuity when they presented with PDR. They developed more complications. They had worse visual acuity before they got lost to follow-up. So in a lot of regards, I do think the results that we found in our study overestimate the outcomes, because the patients who do really bad don't show up. And I think that's one I think caveat with any study, especially with retrospective studies, that those patients who we don't see usually don't do as bad, because usually patients who do well will keep following up with appointments, will keep seeing us, while those who do really bad usually drop off. And I think that's a good caveat we should always be aware of when we look at any of these results. And I think this study also further reflected that, because those patients who never came back had the poorer outcomes, more complications, and things of that nature.
That's a great point. I was pleasantly surprised by how a lot of the patients recovered a good deal of vision eventually when they came back. So there probably is that difference. Farina, a great study looking at the consistent with label cohort. I know we haven't seen that data before, and those patients seem to do really well. Any thoughts on whether they might be actually slightly different or even harder to treat, given that they were given the 4 loading doses? I mean, I know we don't always do that in the real world.
Yeah, that is a great question. I think a couple of things. So for this cohort, what we saw specifically is that the majority of these patients were previously treated. So it is something kind of different to start as you're describing. We do know that in our real world data for early utilization of these anti-VEGF agents that just become available, they are predominantly previously treated eyes. And so it is likely different than the clinical trial cohort. But I also think, and I hope there's more momentum in this area, and I know, Durga, you're doing work in this area as well, around really modeling the on-label use through real-world data, which is a a really nice proxy once these drugs are commercialized and they're available to use in the real world. But in another sense, we would obviously like in our clinical trial setting to have some potential bandwidth for a real world study arm, which is of course very hard to do and has its challenges, but this is a way to study it on the back end that I think is informative and provide some on-face validity to the trial results, given that the results were consistent.
Great points. And Howery, you mentioned some really interesting next steps for your study that you would be looking at patients that were receiving simultaneous injections. Do you have a sense of what your population is for that? I get the impression that not a lot of people are doing same day complement
Yeah,
inhibitors.
yeah. Actually, we have we've been preparing a manuscript on safety data of this the same cohort, and around like 2,000 injections out of more than 1.1 million injections were simultaneous, and a portion of them had AC paracentesis. So we are looking for the best way to represent this data correlation with AC paracentesis at the same day, and the simultaneous versus subsequent injections.
Great. Yeah, I think that'll be really helpful for us as clinicians and could potentially streamline practice if we, from a safety perspective, think same day injections are pretty safe. And Jordan, certainly, last but not least, I think the summit data is really interesting. We really don't have enough real world data on PDS. What's next? I know there's going to be longer term follow up. Are you thinking about looking at DME and DR patients now too?
Yeah, the group that we are doing, it's really been interesting as we're expanding this, looking at a larger subset, and then looking at diabetic patients to be able to get patients out where 95% of the time they need no supplemental treatment over the course of now we're looking at 7.5 months or so, is pretty remarkable. Nothing really else is matching that. It's a new opportunity, and being able to add that to your tool belt is going to be neat in the future.
Great. Well, look forward to seeing that data. Thank you to all of our speakers. It was a great set of talks and really appreciated the answers to the questions. I don't see anything in the chat, so I think we're okay from that perspective. So next we'll move on to our sponsored presentations. Really, really grateful to our sponsors. This would not be possible without all of you. So first we'll start from our very generous sponsor, Genentech, and Dr. Alexandra Warder will be giving a talk.
Thank you, Durga. Hi, everyone. My name is Alexandra Warder. Thank you to the organizers for having us. Today, I'm excited to share how we at Genentech and Roche are using deep learning and AI to extract more meaningful insights from OCT imaging that we get from our clinical trials, how this could shape how we better assess disease severity, predict outcomes, and ultimately improve patient care. The objective is to share a few analyses that we've done and how this could potentially be applied to how we process real-world data. Next slide. These are my disclosures. I work for Genentech. Next slide. Faricimab has a broad real-world data program with over 200,000 patients enrolled in Roche-sponsored studies and over 7,000 independent real-world studies, as seen on the right-hand side. The robust vision gains shown in clinical trials have also been shown in real-world in data in treatment-naive patients. Next slide, please. As presented earlier by Theodore Lang in our NAMD data from Tenaya and Lucerne, we've shown that vision gains demonstrated at year 1 are maintained through year 2. And this was reflected while in the Far Retina NAMD real-world study using data from the IRIS registry across different centers in the US that we've also seen vision gains maintained over time with faricimab. Next slide, please. And as Farina Ali demonstrated earlier, the data from Yosemite and Rhine show robust vision gains with faricimab over time. And this again was well reflected in the Far Retina DME treatment-naive population with consistent vision gains over time. Next slide. So one of the advantages of real world data is that we have a heterogeneous population, a bigger and it's properly reflective of real world treatments, loading phases, etc. One of the disadvantages is that as of yet, we look at data as a two-dimensional image. As seen here on the top left-hand corner, we see a baseline OCT, and oftentimes reading centers will just measure CST, the visual outcomes, number of injections, but we miss a lot of granularity. Here we can see IRF pockets, SRF, hyperreflective foci. This issue of only looking at data through a two-dimensional lens may be at our disadvantage as we lose granularity and lose further understanding of disease progression, disease severity, and associated biomarkers that could predict treatment outcomes. Next slide, please. Our team has started to look at, for example, in this case, hyperreflective foci and IRF from baseline to week 100, I believe it is. 48. We're looking at OCTs in a three-dimensional process. By taking these volumetric cube scans, we can differentiate between these different biomarkers, and we found them to be associated with other treatment outcomes. By looking at three-dimensional information, we may find something a bit more meaningful. Next slide, please. So let's begin with fluid. The impact of early intraretinal fluid reduction at 1 year outcomes in diabetic macular edema. When we look at fluid, oftentimes we think of persistent IRF and how this persistent IRF and DME may affect in our clinical trials as well as our real-world data sets. We ask the question, how does early resolution of IRF impact long-term vision? Next slide, please. So our treatment, our deep learning algorithm started to look at IRF using a volumetric assessment at 3 months and looking at the impact of patient outcomes at 2 years. Here we can see how we've taken in red the IRF. Next slide, please. Next slide. There we go. And assessed over time in our Yosemite and Rhine trials. This post-hoc analysis was based on treatment agnostic from 798 patients. And we looked at changes in IRF volumes after 1 and 3 monthly injections, the true head-to-head period, and then further looked at them at 1 and 2 year anatomic visual outcomes in DME. Next slide. We categorize patients into 3 groups based on that initial IRF resolution after 3 months. Group 1, which is in red, was a reduction of 20%. Group 2 in green was intermediate, a reduction of 20 to 50%. And group 3 with a reduction of over 50%. Baseline characteristics were well balanced across all 3 groups. And among the 798 patients with data available at the selected time points in Yosemite and Rhine, these patients were further than separated. We followed the analysis by looking at the post-hoc analysis of protocol I, and our data is based again on a treatment agnostic data set. Both faricimab and aflibercept treated arms from the Yosemite and Rhine trials were included. At 3 months, IRF volume was reduced by 20% in 98 patients, 20 to 50% in 173 patients, and over 50% in 527 patients. Next slide, please. It's a build. Next, there you go. We found that those in group 3 had significant better BCVA at 2 years. So patients that had quickest reduction of IRF in the initial 3 months ended up having better visual outcomes at 2 years, thus supporting the hypothesis that early IRF resolution contributed to longer visual outcomes. BCVA change from baseline was nominally greater in groups 2 and 3 compared with group 1 at 2 years. The adjusted mean BCVA change from baseline at 2 years was 7.4, 11.0, and 12.1 letters, respectively, amongst the 3 groups, a difference of almost 5 letters between groups 1 and 3. On the right side, plot group 3 with a reduction of over 50% of IRF at 3 months had the highest proportion of patients who gained over 15 letters at year 2. The proportion of patients in group 3 is 2 times higher than that in group 1. Next slide, please. So moving on to another biomarker, hyperreflective foci in DME. We've realized that this is a key biomarker in disease severity for DME. While looking at hyperreflective foci, we define these as less than 50 microns in diameter, highly reflective dots on the SDOCT. There are two hypotheses that these are activated inflammatory cells and/or lipid and protein extravasation. These present both in many retinal diseases, but primarily mostly in DME and AMD. We've seen studies that these reduce with treatment of anti-VEGF and steroids, so we decided to look into these. The hypothesis here was that the presence of baseline hyperreflective foci was suggestive to be a predictor of poor visual outcomes in patients with DME. Next slide. So we looked at this again using deep learning. We segmented HRF, again defined as less than 50 microns across entire OCT volumes up to week 48 in Yosemite and Rhine. These were automatically segmented from the whole SDOCT scans, and we used these deep learning to evaluate. We used both en-phase images as well as the OCT. In the en-phase, you can see these as red, and the OCT again as red. Next slide, please. So of importance, why did IRF volumes matter? How did we associate them? The clinical correlation. When stratifying the HRFs in volume quartiles, we saw greater baseline HRF correlated with worse DRSS severity and thicker retinas. In the 3 millimeter diameter zone, more IRF was associated with lower baseline BCVA at baseline. We evaluated these by quartiles in a treatment agnostic manner. And again, more baseline HRF volume had increasingly DRSS severity and CST in the 1 and 3 diameters. And for BCVA of very clinical importance, greater baseline HRF volumes were associated by decreasing visual acuity in the 3 millimeters. Next slide. We additionally found that a colocalization between HRF and IRF, supporting the inflammatory hypothesis and thus opening further research questions. You can see in the en-phase images, IRF in blue and HRF in red. Next slide. So in conclusion, volumetric assessment of HRF in Yosemite and Rhine demonstrated, in this case, in our non-treatment agnostic, that faricimab resulted in greater resolution of HRF versus aflibercept and DME. At baseline, greater HRF volumes were associated with increasing DRSS and CST, suggesting that HRF is linked to higher disease severity in DME. The correlation between HRF and IRF distributions on the en-phase projections. And we found that HRF volume and count reductions were greater over time to week 48 with faricimab versus aflibercept. Next slide, please. So our third analysis that I wanted to share today is the greater reduction of hard exudates in faricimab versus aflibercept patients with DME, a biomarker that we found correlated to clinical outcomes in our phase 3 clinical trial. Next slide. When defining hard exudates, we define them as lipoproteinaceous aggregates deposited primarily in the outer plexiform layer of the retina and a hallmark of DME. And our hypothesis was that reduction of HEs resulted in after intravitreal injections, and these were representative of a useful biomarker for disease severity and treatment response. Next slide. Our methods, again, we looked at this. We can go to the next slide, please. In a volumetric way, where we compared reading center counts that suggested that took into account HEs as those hyperreflective dots that were larger than 50 microns in diameter. And we overlaid them with our volumetric assessment using deep learning-based algorithms in these cube forms. And here you can see through the volume, as well as the en-phase view, measuring the volumetric in nanoliters and the hard exudate count in microns. Next slide. So here we have the baseline characteristics. At baseline, 81% of patients had hard exudates. This was interesting, considering especially because our clinical trials had a limit of A1C of 10%. There was numerical differences in baseline characteristics with patients who had heart exudates. They were on the younger age, had shorter DME diagnosis, thicker CST, larger macular leakage areas, and worse DRSS severity. A lower proportion were white, had systemic hypertension, were receiving lipid-modifying agents, and had received prior anti-VEGF therapy. A higher proportion had macular ischemic non-perfusion and were phakic. Next slide. More interestingly and clinically meaningful, patients with heart exudates had slower CST and BCVA improvements in the early treatment phase, this head-to-head. Even though patients with heart exudates eventually caught up visually, their delayed response suggests perhaps that heart exudates may represent a higher disease burden and importance of paying attention to these lesions and their responses. Next slide. So in conclusion, learning about these deep learning, machine learning, and AI, harnessing this and applying it to real world data could potentially improve the way we understand disease severity, treatment outcomes. AI volumetric analysis allow us to translate anatomic features into clinically meaningful measures that align closely with function outcomes we've seen in the real world. Applying machine learning in real world may help validate and extend clinical findings, such as those that we found in Yosemite and Rhine, providing confidence that observed benefits translate to routine care. Automated and 3D quantitative imaging allows detection of subtle disease patterns, co-localization of biomarkers, and early indicators of treatment response. And applying this to large-scale standardized OCT extraction, AI opens the door to predictive modeling, enabling better stratification of patients and proactive disease management. Thank you.
Great, thank you. And next we'll have a video from Astellas. Great. Thank you so much to our generous sponsors, Genentech, Astellas, and Regeneron. With this, we'll be moving on to the next session with focusing on AI and real world data. And I'll pass it over to my colleague, Brian Vanderbeek from the University of Pennsylvania. Thanks, Brian.
Thank you, Durga, and welcome everyone. Thank you for being with us today. I'm excited to announce and moderate our session on AI and real world data. First up, we have Brian Athey discussing information security for AI models in ophthalmology. Brian, take it away.
Thank you, Brian. Another Brian here. Can you hear me okay?
Yes, we can.
Oh, good. Thanks. I am a department chair and founding a department chair of computational medicine and bioinformatics at the University of Michigan Medical School. And I'm also a professor of psychiatry and actually of internal medicine also. And I'm serving as the lead AI systems architect for the Mary Tyler Moore Vision Initiative, which is based here in Ann Arbor and has partners all over the place. I have no disclosures. Let's see. So what yeah, let me see. Here we go. Maybe let me have the next slide. Oh, good. Here's an outline. First of all, I want to show the test bed because that's the real key to the whole thing. Because what we have is a very diverse set of partners in our Mary Tyler Moore Vision Initiative. And with artificial intelligence now just permeating all different aspects of our work, there are new challenges that are popping up in information security. Think of me as a kind of a chief digital officer of the Mary Tyler Moore Vision Initiative for this presentation. I have served previously as a chief information officer of our health system, so I get that. But actually, things are changing now. We have information assurance, we have compliance, and we have the systems that supply our capability, and all those are changing right now because of the AI. And some of the new challenges that I just want to briefly touch on are data privacy and re-identification, which has been around for a long time, cross-institutional data and information sharing, cybersecurity and adversarial threats, including deepfakes, data ownership, consent and governance, very important part, transparency, bias, and fairness. We know about that for sure with AI systems, the need for new regulatory and ethical solutions for the challenges, and special things that are popping up with the agentic AI systems. And then what I want to just mention at the end is privacy preserving federation methods are really, I think, fundamental to our future to establish the best way forward. Let me see if I can get this to work now. I hit the, maybe go to the next slide. Okay, this is just this is an overview of the test bed of our Mary Tyler Moore Vision Initiative, and you can see in the center the different academic players, and you can see, but just below that, an important partner with pharmaceutical that's wanting to leverage all our data, and you can see kind of the additional partners, including I might mention Topcom, which is a very important partner that's establishing the ability to bring in all kinds of imaging data. So not only do we have a lot of different kinds of players, you can see the Joslin, you can see Harvard, you can see all that, but you can also see the, kind of the multimodality of the system. Next slide. Okay, so here's the data privacy and re-identification piece, and I think just focusing in on the highlighted areas. The large imaging data sets, and remember, we're using AI now, so we have these large, huge growing data sets, and we've seen this morning from the talks in Singapore and the talk from Genentech. There are residual risks of de-identification. I think we all know that what we can do is now just link up different things from different sources and identify things. So the traditional de-identification methods just aren't going to cut it. And so what we need is something deeper than that. And what we'll talk about is what that is going to be. And just remember that things are accelerating in terms of new threats that are being enabled by the AI. Next slide. Here's the cross-institutional data and information sharing, kind of some of the compliance issues. And we all talk about HIPAA, but I just want to underline the NIST SP 800-171 standard, which is now required by the government agencies as the standard that we must implement in our infrastructure to allow for the better security and privacy of our data. And the HIPAA standard was established in 1996. This new standard, which is a requirement, it's actually quite costly. For our research computing systems in Ann Arbor, it's costing us about $4 million to make this change. So that'll give you a kind of a sense for what that's about. Next slide. In terms of cybersecurity, adversarial threats, and I threw in the deep fakes here, what I'd like to just say here is that, robust encryption end to end for all the different things. And then, adding that with the federation we're going to talk about in a minute is going to really help. But the deep fakes are, because they're so indistinguishable from real representations, are really something that we have to be worrying about from adversaries. And we do have adversaries. Next slide, please. Okay, and so data ownership, consent, and governance. I think that for me, the key word is governance, because what we need to do is put policies in place that protect the patients, the providers, the participants, the research partners, the pharma companies, the academics, all the different kinds of partners, and in their journey from basic all the way to translation. And that's got to be set up as a policy and governance framework from the beginning. Next slide. And the key word here, is there's a balance. I mean, we have to have the transparency. We have to not perpetuate bias, but actually eliminate it whenever we can. And this is going to be that we will see an emerging issues, as I'm sure that will pop up and be surprising for us. So the key piece is, if we don't proactively do this, we will reduce trust in our partners. And trust is the things that we really need to keep going. And notice the word data provenance. It's not highlighted, but it does mean that we have to, and artificial intelligence can be used to accelerate our ability to keep track of this over time, because the data volumes are actually huge, and petabytes of data that we're looking at. Next slide. And so here, thinking about these challenges, I think that the challenges are each and every one of us, either locally or nationally or internationally, have, different kind of regulations that we have to adhere to. And so that when we bring our teams together, we have to have something that works for all of us. And it's only going to be happening if we set the policy and the government's framework in the idea of evolving legal and ethical challenges and standards, because these are kind of, especially the legal and ethical, they're coming up new every day. Next slide. Okay, this is an example. Yesterday, I had a chance to participate in a discussion with David Rue, who's the Chief Medical Officer for Microsoft Corporation. And this is his slide there that he shared with me, thinking about the next kid on the block was orchestrator, agents. And agents are something that are going to be really hard to handle. And they're, if you're an information assurance officer or a CDIO or something like this is your nightmare. I mean, and really what we're going to need is a privacy-preserving enclave cloud system that's going to allow for us to handle all this in a safe and secure way. Because what you're going to see is that each one of these agents, this ideally is connected with a real person, and they operate as a team, and they deliver a workflow that is semi-automated at best. Automated agentic workflows are being proposed right and left, but boy, they're certainly dangerous. And so we have to be cautious, and we need a separate environment for this. Next slide. Okay, here's this young fellow visited me recently and gave a seminar in our department, and I was really, really impressed with him, assistant professor at Yale, and I wanted to share this slide, and he's got another one that shows this, like going all the way to multi-omics in the phenome, but this can show you that in the center you have this multi-party computational infrastructure that is that's actually is the secure enclave that's fully encrypted, and data coming in and out from the partners are encrypted with the homeomorphic encryption algorithms and other algorithms. You can see, in a fairly classical example now, bringing together the data from these different, the eMERGE consortium, UK Biobank and IAMDC. You can see the big number of participants, and this is the example of a pooled GWAS, Genome-Wide Association study. But this could be done all up and down for the genotype, the multi-ohm, systems-oriented phenotypes, and populations of instances. So we can do personalized stratification as well as kind of research that looks at population and outcomes. Next slide. The key is the federation, the key is the encryption. So here's some conclusions to consider. Information security for AI models in ophthalmology requires centralized team-based planning, evolving policies, and governance models. That is absolutely key. When we build teams, and for example, you can see the nice work that's being done by Genentech and the other partners. This is for every project and every consortium. We have to do this from the top down, and we have to get bottom-up participation organically. The ethical and legal considerations must be considered up front and evolve as the team and problems change and evolve. And that's, I think, absolutely critical. I've mentioned federated architectures, end-to-end encryption, and secure private enclave cloud systems. They're an absolute requirement for this kind of work. And all personnel and participants need to be informed of systems and methods to preserve privacy and ownership of what is rightfully theirs. And so I just want to thank all of you for allowing me to participate in this discussion. And Brian, I'll turn it back to you. And if there are any questions, I'd be happy to answer them. And thank you for having
me. Thank you, Dr. Hathi. I just want to remind people who are listening in, please ask questions, but please put them in the chat. We will have a chance to discuss the questions later. Next up, we have Menggu Wang discussing deep learning with disk photos or optical coherence tomography scans and glaucoma detection.
Okay. Yeah, thank you. Today my topic is about do we need OCT or fundus photo is good enough for glaucoma screening with deep learning? In the past decade, numerous work have been done for using deep learning to detect glaucoma using fundus photo. If you look at those papers published in JAMA Ophthalmology, they all got good performance. They have AUC 94%, 99%, 98%. So it seems just using fundus photo with deep learning, you have good enough AUC performance for practical use for glaucoma screening. But there's only one caveat. In most of those studies, the ground truth is based on clinical visual examination of the fundus photo alone. And the visual field test is not used for defining the ground truth, but obviously in clinical practice, the visual field should be part of the glaucoma diagnosis. So in this study, we test the hypothesis when you define glaucoma with functional test, and do OCT scan perform better than fundus photos? And we use about 17 pairs of fundus photos and spectral domain OCT scans obtained at Mason Year between 2011 and 2022. And the time difference between the fundus photo and OCT scan should not be greater than a half year. And neurofibrillary thickness map was used to represent OCT measurements. and VGG19 was used to predict glaucoma diagnosis. And here are just the data characteristic distribution across different races, sex group, and ethnicities, and also the data characteristic distribution between training and testing. So let's see our key findings. Yeah, actually, when you define glaucoma using functional test versus clinical visual examination, the OCT significantly outperforms fundus photos. Actually, in this case, fundus photo doesn't perform that good. It has AUC of 86% versus OCT's 90%. And also, when you compare the AUC performance across different racial, sex, and ethnicity group, OCT has much smaller performance disparity. And we further show some quality examples to see when this photo gives a correct prediction and when OCT gives a correct prediction. And we have observed oftentimes when you have low quality fundus photo with hazy appearance of the optic nerve head, this photo could make a mistake for predicting glaucoma diagnosis. So that's all. Yeah, so our key conclusion essentially, be careful when your glaucoma definition is involves functional test. Actually, the fundus photo doesn't perform as good as you think. So there is still some further improvement need to have practical usable deep learning screening models. Thank you very much. My presentation is done.
Thank you. Excellent talk, Dr. Wang. Next, we have Kaveri Thakur from Columbia University giving us a talk, A Practical Guide to Evaluating Artificial Intelligence Imaging Models in Scientific Literature.
Great, thank you. And yeah, I'm honored to be here today to be speaking about a topic which is quite unique compared to what I normally get to present about, which is evaluating AI imaging models in scientific literature. And the content of this actually is based on an Ophthalmology Science article, which was spearheaded by my research year medical student, Angela McCarthy. And this topic is basically tailored more to an AI naive audience, but I think it's actually a great refresher also to seasoned AI data scientists and engineers because of the critical issues involved. So just to give some context, we are a group of AI for Vision Science Lab at Columbia. We're a group of engineers situated in the ophthalmology department. So it's really our charter to enable the translation of these models to the clinic in a ethical and safe manner. And we do that by creating this medical expert AI team that's hopefully better than either the sum of its parts, by ensuring our models are robust, interpretable, and portable. So by robustness, I mean models that leverage 3D volumetric data to enhance model performance, and also federated learning infrastructure to enhance generalizability while maintaining model and data privacy. And towards interpretability, we leverage eye movements of medical experts to inform AI systems, and vice versa, also AI attention mechanisms to potentially inform experts of novel ocular biomarkers. And towards portability, we try to develop AI that's interoperable across data of varying quality and manufacturers. But today, I'm really going to talk to you about a fourth axis of our work, which is towards ethics and AI. So developing the ethical development of AI models. And so to set the stage, let me just give a high-level overview of what is at the heart of the AI image classification pipeline. So it starts, of course, with data set curation. So our models can only be good as the data going in. So ideally, we want a large data set that's diverse and really representative of the real world populations. Then, of course, is the actual model training. So being able to extract patterns from this data using supervised or unsupervised methods to perform a task, for example, detecting glaucoma from OCT images. Then comes the phase of testing. So either first on retrospective data, so data that has already been collected, but then important for deployment is performance on prospective data in real time to data that the model has never seen before. And then finally, once the model has passed some threshold of performance, for example, for glaucoma, maybe high specificity and sensitivity because of the low prevalence of the disease, then we can move on to clinical implementation, such as randomized controlled trials. So just digging a little bit deeper into some of these, starting with the training data, as I mentioned, we want large data sets, ideally on the order of hundreds or thousands. For example, OCTs, if we're dealing with a model to detect glaucoma from OCT data, but also diverse data. And what we found in our review is that actually there was a scoping review that found only a fraction of the trials that they reviewed actually presented information on age and gender composition and also race and ethnicity. So of course, it makes it hard to trust a model if you don't know how it's going to perform on so specifically underrepresented data, underrepresented groups. So the take-home point is really trust models that report demographics, and also when you're developing your own models, try to report the demographics and performance on various subgroups, both in terms of race and ethnicity and also disease severity. Another issue about within training is data augmentation. So this ability to enhance the size and diversity of data set by using anatomically plausible transformations such as rotation, zooming, flipping, and other image processing techniques. And of course, this can be great to enhance the generalizability and real-world variability of data sets when that isn't present in the training. But it can also, we must be wary that the augmentations used are actually clinically valid. For example, doing a flip around the y-axis would make sense, but not necessarily along the x-axis. And so here are some other examples of some valid data augmentations. So now to kind of summarize and provide a checklist of things to think about to evaluate AI models. So we talked about data set size and ideally large data set with disease severity, and also demographic representation. And if a model is not fully representative, then think about potential biases that could be present in the model's performance. Data augmentation, making sure that what fraction of the data is augmented and whether it's using clinically valid augmentations. And then also some things that we didn't touch on directly, but labeling methods for the ground truth. Ideally, they should come from a consensus rather than a single expert. And if testing is done, then prospective testing is really key, especially for deployment. And then also interpretability and explainability, especially some kind of class activation maps for convolutional methods or attention visualizations for transformer-based methods. And so just to give a teaser for some of our future work, we are practicing what we preach, and actually we have a glaucoma pilot AI study underway where we're taking one of our high-performing glaucoma models and vetting it through prospective testing in the clinic, and we will be presenting our subgroup analysis. And one unique thing we're also planning to do is show the performance of our model with and without performance of our clinicians in their downstream diagnosis with and without the AI. So with that, I'd like to thank my team and also my funding sources and all of you, and especially Angela, who's pictured here, for her work on this, and look forward to the discussion afterward. Thank you.
Thank you. A lot to think about. Thank you. Excellent talk. Next, we have Angelica Lee, Stakeholders' Perspectives of Implementation Barriers to Artificial Intelligence for Digital Diagnosis in Eye Care.
Hi, all. Good to be with you today. I'll note that this work was funded by Roche Products Australia. So AMD is a major cause of vision loss in people aged over 55 with a global prevalence of 8.7%. We know it presents in the 3 stages, early, intermediate, and advanced, with the advanced neovascular subtype being the most visually devastating. Unfortunately, AMD is frequently misdiagnosed or diagnosed late, contributing to preventable vision-related disability worldwide. AI-based diagnostic tools, fortunately using fundus photography or OCT, are emerging to screen, diagnose, triage, and prognosticate AMD. And despite the promising results, though, widespread adoption remains limited. Some of the known key barriers already to adoption include things like cost, convenience, patient satisfaction, among others. And while these general barriers to AI and eye care are known, the specific challenges for AMD-focused digital diagnosis are less understood. So the aim of our study was to explore stakeholder perspectives on digital diagnosis for AMD in Australia. We conducted a qualitative semi-structured interview study using purposive criterion sampling and our professional networks to recruit a diverse group of stakeholders. All participants were aged 18 plus with experience or interest in macular disease. The interviews were conducted in English via Zoom by 2 experienced female postdoctoral researchers using a single standard interview guide that covered 5 core topics. Firstly, participant experiences with AI, digital diagnosis for AMD, the attitudes, enablers, barriers, and the possible futures. All interviews were audio recorded, transcribed verbatim, and analysed using qualitative analysis software in vivo. We used directed content analysis using a predefined codebook with 29 subdomains. The coding was led by second author Sarita Hersey, and I developed the transcriptions for each subdomain. We held regular team meetings to ensure coding reliability and consistency, and applied summative content analysis to quantify the comment frequency, looking for differences across stakeholder types and domains. We use the NAS framework, which stands for the Non-Adoption, Abandonment, Scale-Up, and Sustainability and Spread of Healthcare Technologies, which is a really comprehensive framework designed to allow us to analyse the adoption of healthcare technologies, which it comprises as well 7 socio-technical domains, 22 subdomains, and we additionally incorporated 7 AI-specific subdomains, which were added by Garma et al. The results, we found that in total, we got a response rate of about 25% and included 12 clinicians, 10 healthcare leaders, 8 patients with AMD of varying disease severity, as well as 7 developers. The interviews lasted on average 30 minutes, about half were female, and there was a mean age of 50.1 years across the participants. This figure is a little bit involved, but shows the frequency count by stakeholder type of all the data, of all the qualitative comments. And what we found generally was that there were differences in, I guess, the key areas of focus by the different stakeholder types. Patients, for example, tended to focus on their own personal experiences of the condition. Clinicians and healthcare developers, researchers, technologists tended to be most similarly aligned and focused on kind of local needs of the technology, whereas healthcare leaders tended to focus more on organizational or implementation challenges at a broader level. Going through just a few of the subdomains in interest of time, but thinking firstly about the condition. AMD as a condition was generally viewed as amenable to AI diagnostic technology by most of the stakeholders due to diagnostic uncertainty, having complex disease subtypes, a lack of effective monitoring options, risk of second eye involvement, and a limited capacity of existing change analysis. The technology itself was perceived that a key feature would be a portable device agnostic clinical decision aid integrated into existing equipment and patient management systems. From a value proposition perspective, clinicians view value as being able to see more patients at risk with greater confidence in diagnosis and for better patient outcomes. Organizations perceived as innovators in the space were seen as kind of early adopters, forward-thinking, opportunistic, disruptive, with an interest in commercialization and multidisciplinary leadership. Domain 6 would be the wider system equity across population groups, socioeconomic status, culturally and linguistically diverse groups, as well as the level of health literacy and location were also all considered important. So in total, these results show that tailoring solutions to unique concerns of patients, clinicians, developers and leaders may lead to more effective and wide-scale adoption. Participating stakeholders collectively foresaw a fee-for-service model, particularly useful in remote settings and for monitoring of neovascular AMD in Australia, recognising the potential about removing barriers to healthcare access, particularly in these areas where there may be a skilled image grader shortage. Caution integrating AI into real-world settings was recommended due to concerns particularly about accuracy, generalizability to their specific populations, equity, and the importance of human oversight in clinical decision-making. Our study's strength lies in its purposive sampling of knowledgeable stakeholders, enabling a broad exploration of digital diagnosis in AMD, though we acknowledge that some of the limitations include the absence of patient carers, regulators, and policymakers in our participant pool. It was also skewed toward English-speaking individuals, limiting generalizability to other groups and diseases. And data saturation was also not pursued. But in conclusion, this was the first study to present diverse interacting stakeholder perspectives on adopting digital diagnosis for AMD in Australia. And it is published in Ophthalmic and Physiological Optics, so I've included a QR code link on screen here. Thank you.
Thank you. Excellent talk. Next, we have Dr. Michael Boland from Mass Eye and Ear discussing how real is the real world. Watch out for systematic bias.
Great. So I'm realizing I'm at the point in my career where one of my jobs now is to remind us of things that we've learned at least once before. And I'll have to have someone advance that. Okay, maybe we got it to go now. All right. So almost works. All right. So first, the big lesson, big theme from today is going to be that big data does not equal better data. Hopefully, we'll make that clear. I'll give you an example here. This includes a large data set that includes some ophthalmology-related data. And you can see these two measures are highly correlated. So if you found this in one of the big data sets we've seen so far, you'd be very excited, and this would generate some newsworthy publication. But if I tell you that this is actually the number of movies that Ewan McGregor appeared in that year versus the number of ophthalmic technicians in Connecticut, it's much less exciting and much less plausible. So we have to be careful with what we conclude with large data. So let's talk quickly about some of the sort of theory behind bias, right? We'll talk about the examples of bias, then we'll go over a couple examples. So first of all, any kind of data, and whenever you see study here, you can replace that with data set, right? Because people get into your data set through the same kind of process. So first, there's sampling bias, right? So depending how they were selected, that's key for deciding what kind of conclusions you can make. There's attrition bias, so not only how they got in, but how do they get out? So people drop out of your clinic, maybe they're no longer in your data set, and so are missing. Next example is volunteer bias is related, so who's actually showing up to be in the data set. Survivorship bias, right? This is the example of like, people who today are like, well, I survived not having seatbelts back in the day, but that's because all of our colleagues and friends that didn't survive the car crash are no longer here to tell us the other side of that story. There's the non-response bias is related to some of these other ones, right? So people who don't respond, if you're doing a prospective thing, they're not interested. And then similarly, the undercoverage bias, we got at this in the previous presentation and some earlier ones today. If we're not sampling a whole population, we're going to have biased results that don't work great across populations. All right, so other category of bias is information bias. This is particularly relevant to some of these data sets we've talked about so far. So first is recall bias. So anything that's patient reported, right? If you had a bad outcome from a pregnancy, you're more likely to recall taking certain medications during your pregnancy than if everything went fine. Another example of that. In our case, the observer bias, I think, is important. So what are the doctors doing differently? So I might, for example, be more likely to document a particular finding if I've already made the diagnosis in my head, right? And then so you're going to more likely find a correlation between those two things, even though I'm missing those findings in other people where I'm not thinking of that diagnosis. And then performance bias, right? So I'm not picking the same patients for all of my tubes, trabeculectomies, MIGS devices, et cetera. So how I selected those people to get those procedures is not included anywhere in the analysis. There's no way to undo what's going on in my head when I make those decisions. And then regression to the mean is a thing that we all know about, and it's particularly relevant to some of the things we talk about here. If I have a really bad IOP to start with, I'm more likely to end up in your data set, maybe not really informative because I would have regressed back to normal pressures at the next exam anyway. So some examples. So I've picked some examples from my hometown journal and a study run out of a hometown hospital here in Boston. So this is the Nurses' Health Study and some of its early findings. And so they studied nurses prospectively even, but it was very well done, highly funded study, well designed and high quality data. And one of their initial conclusions was that estrogen replacement was associated with less cardiovascular disease and less mortality. So this is a life-saving intervention we should be giving everybody based on that result. Similarly, we have vitamin E consumption and the risk of coronary artery disease. And they found something similar, which was that the nurses who were taking vitamin E supplementation had reduced risk of coronary artery disease. So both of those stimulated randomized controlled trials, prospective data. So the first of those looked at the estrogen replacement. And as many of us now know, what they found was that overall estrogen replacement was harmful in that same population. So the opposite finding, and that really changed care at that point. And similarly, with vitamin E supplementation, they did the same kind of randomized controlled study and found that there was no benefit of vitamin E in cardiovascular outcomes. All right, so what went wrong here? So I think two things to think about. So there's in the information bias side, there's a recall bias. Maybe the nurses who reported taking certain supplements previously were not taking as much as they thought, or their diet was not as rich in vitamin E. Selection bias obviously is key here. We got nurses as a fairly specific group. They're all volunteering to be part of the study. And there's a survivorship question here. People who were sick and maybe got out would no longer be included in the study. So there was a group that actually looked at that nurses' health study over time, and I think this is relevant to the studies we're talking about here, and found that of 19 associations found in the nurses' health study that were subsequently studied with randomized controlled trials, less than a quarter of them were actually confirmed. So the vast majority of them found not to be supported by randomized evidence. And I think this is relevant since this session is about AI to remind ourselves something we've heard already a couple times, and that is that we already have seeing evidence of AI being applied to data sets that include bias in terms of populations. And so we've got those failing based on being shown data from other populations. All right, so conclusions are real world data clearly are valuable. I think they also are clearly biased in ways that we don't always know. And I think we need to make sure we're very careful about conclusions that we're drawing from these real world data sets and limit them to something we can actually conclude and not draw too much from them over time. Thank you.
Thank you, Michael. Excellent talk. Next, we have Aline Lutz de Arujo talking privacy preserving integration of multimodal data sets for neuro-ophthalmology research through tokenization.
Thank you, Brian. Can you hear me?
Yes, yes, we can.
Okay. Okay, thank you. So it's a long title, but actually I'm going to talk about how to create data sets when you need to combine different sources of data, how to link those data sets. And here I brought two examples of neuro-ophthalmology. So I'm taking a step back from the AI development or whatever is the use of data and just how we can compile those data sets. Okay, so the main challenge with compiling multimodal data sets is that data is stored in silos, and it can happen even within the same institution, or even more so when we need to combine data from different sources. Let's say a patient that goes to a private practice for eye care, then the same patient goes to a lab, and then to the hospital, to the ER. So then we have different sources of information or data that is stored in multiple places for the same patient. Whenever we use real-world data, in most circumstances, we are dealing with data that has been already de-identified, which is great. We don't want to expose patients, so there's all this concern about patient privacy, but it also increases our difficulty in mapping different data sets for those same patients. So de-identification poses an additional challenge for combining multimodal data sets. So one solution to overcome data that comes from different sources is to use token. So tokenization is provided by different companies. I personally use DataVent, and that's what I'm going to show you today. There are other tokens. There's from HealthVerity. IQVIA also has their own tokenization system. And by the tokenization basically means that each patient ID will generate a different ID, which we call token, and this can allow us to combine data from the EHR or medical images, or if there's a registry for patient-reported outcomes, omics data, claims, and so on. Social determinants of health, all that is out there, we can potentially combine if the data has been tokenized. So the objective of my presentation is to report an empirical experiment to link ophthalmic clinical data with radiology images using token overlap. So the objective was to create two data sets, one for demyelinating disease, focusing on multiple sclerosis, and the second one for neurodegenerative diseases, focusing on cognitive decline, dementia, and Alzheimer's disease. So here's just one example. So this is a data set that we created for Alzheimer's. And when I say multimodal, it really means multimodal, not only from the eye imaging data set, but also from the brain imaging data set. So each of those modalities, MR, CT, tau PET, and amyloid PET, will provide different imaging biomarkers, which can be important for the research. So what we did to create those data sets, we tokenized SegMeds. SegMed is the company that I work for. So we have a very, very large radiology imaging database and uploaded the tokens to Data Event Portal. And then we ran an overlap with IRIS registry, which is managed by Verana Health and contains 84 million patients data for ophthalmic visits. And then we exported the overlap tokens to check both the diagnosis and the imaging data availability. So for this experiment, we used only New York State data, basically because we started by tokenizing the data that we have like per state. And at this point, we had more data tokenized. In New York, we had 1.5 million patients with radiology data from New York. So the result of the overlap between IRIS registry and SegMed radiology data set was 607,000 patients. But then, of course, not all these patients would have the images that we were looking for. So the next step is to get the tokens out of the platform and check the images that each patient had. And then here's the final data set for demyelinating. For each of the data set, actually, we had over 1,000 patients. For demyelinating disease, we had more patients with longitudinal data, meaning that multiple patients, 78% of patients had multiple time points, whereas for neurodegenerative diseases, most patients had only a single time point of brain images. So in conclusions, we created two multimodal data sets from real-world data to support brain imaging research for both neurologic conditions. Personally, identified information was replaced with encrypted tokens and matched across databases. And other use cases for tokenized databases include AI development, oculomics, and real-world evidence applications. And that's it. Thank you.
Great. Thank you. Very interesting talk. All right. If we could have our speakers come back now, we have some questions that we can answer or we'd like to have answered. All excellent talks. Let me see. All right. Let's start with you, Dr. Thakur. You discussed external validation along ethical lines. When is enough testing done to consider it externalized? So I guess, I don't know, I guess I wouldn't think it would be unethical to use a system outside of the one that you started it on. But and thinking more about it, I could see where there would be issues with that. So how do you combine the two and make sure that you're moving in a safe, ethical way?
Yeah, that's a really good question. I think what might be a good benchmark to use is actually some of the guidelines provided by the FDA. So they have a very, I'm also just learning about this now for some of our work, but they have a very extensive requirement of prospective testing before models can be considered FDA approved. And so and also now more regulatory bodies are coming up with requiring more and more things to be presented, for example, subgroup analysis and even model cards to detail what kind of data was used, what kind of retrospective and prospective testing was done. So I think starting from some of those benchmarks is a good place to build satisfaction with putting your model out there. But also another thing which maybe isn't quantified as much is the impact on clinical care as a result of having the model in practice. So I think that's one thing which maybe we're still figuring out as a community, but hopefully with more and more studies coming out to actually see not just what is the model's performance on retrospective data in isolation, but what is the model's performance, what is the expert's performance as a result of having the model in the loop.
Very interesting. Thank you. And Dr. Athey, you discussed how AI models may re-identify patients. Certainly, in some instances, having the information within the AI model would be really useful. So how do we balance that by allowing the AI model to kind of get useful, re-identifiable information like, suggested birth, or sex, gender, age, all of those things without necessarily allowing it to actually become re-identifiable?
Yeah, well, years ago, informatics concept, we developed a idea called the honest broker, and it was something that really sat in the middle that allowed us to, de-encrypt the code when you had the right permissions to do so. And I think there is no doubt about the fact that there's sometimes when we want to identify participants in a study or patients by trusted individuals within the context of the policies and governance. And so I think that has to be included in the technical specification for sure, and often is. And then you have opt-in and opt-out criteria to provide another level of security, privacy.
Very good. Thank you.
Thank you for asking this very important question, and it has to be architected into the system.
Very good. And Dr. Bolin, thank you for uncovering the most important fact of the day, which is Ewan McGregor clearly hires lots of ophthalmic techs with every movie he does in Connecticut. But on a more serious note, I think we all struggle with when trying to decide something is quote unquote true or likely, at the very least likely. We get presented with all these studies at some point, and at some point they move from, okay, this is a possibility to a likelihood. How do you go about making that decision and, keeping in mind the different biases?
Yeah, I think it's really based on the kinds of studies that we're talking about, right? So I constantly have junior colleagues working with IRIS and other big data sets to try to include the conclusions being, oh, we should change practice based on this finding that such and such worked better than such and such. But the biases against, how those procedures were selected are so large, you can't possibly say that. So it's mostly based on the quality of evidence. And then there's something about plausibility, right? So you really want to have some sort of physiology, something that helps you decide that what you're seeing is going to be a real phenomenon.
Fair enough. Thank you. And Dr. Lee, you discussed a lot of the different domains and the barriers that are, impediment to getting AI implemented specific to AMD. Is there a way to rate the different domains as to what might be most limiting? What can you attack first to try and get AI into the real world setting, or clinical setting, I should say?
We do actually have a sub-analysis, so a separate paper coming out specifically honed in on the barriers across the domains. Challenge with this kind of data is obviously weighting it, given it was a subsample, just as I said, kind of the select population of participants. Broadly, we know a lot of the challenges, and it's also interesting to think about the enablers too. Across the domains, I mean, pleasingly, I think we're seeing certain conditions more amenable. So certainly you can see the patient and clinician demand for AMD solutions specifically, simply because, again, compared to maybe a condition like glaucoma where there might be more diagnostic ambiguity, I think that was definitely showing up in the data, and the lack of effective monitoring options, the need for kind of more robust change analysis, particularly when we're dealing with multiple imaging data sets across visits.
Very good. And Dr. Wang, how close do you feel like we are to having glaucoma become an AI image-based diagnosis as opposed to more of a straight clinical one?
I think it really depends where you use such screening, those AI model-based screening. I believe more and more people, they will attempt to use ChatGPT or Gemini to do self-diagnosis. I think regardless doctor, ophthalmologist, they like it or they don't like it, they will attempt to do that. I think from the practical use perspective, we should find some way to enhance those, to have some guideline. If they really want to do that, how you should do it. So recently we have found actually if you can provide some reference cases to ChatGPT or Gemini, those generic language model, if you provide some reference cases to those language models, actually they can self-adjust the prediction to make the telemedicine prediction better. So I would say like people will use that because the AI model is everywhere.
Very good. Thank you. And thank you all to our all of our session 3 speakers. We're going to move to session 4 now, which is titled Anterior Segment and Uveitis. However, due to a technical difficulty, Dr. Ashad Khani was not able to give his talk, so we are going to fit him in here. We are appreciative for him being able to speak with us today. So we will take a quick break before we get into the and go back to retina before we get into the other aspects of the eye. So Dr. Khani is going to talk real-world efficacy and safety of faricimab and neovascular age-related macular degeneration, latest results from the Truckee study.
Thank you, Brian. Thank you to Rishi, Durga, and the organizers for allowing me to share this data. Here are the co-authors that have participated and contributed to this data set. Here are my disclosures. So what is the Truckee study? It's a real-world study that we launched almost 4 years ago, looking at efficacy and safety of faricimab in real-world neovascular AMD patients. So target population is treatment naive as well as treatment experienced. And the reason for this was that the Tenaya Lucerne studies that were pivotal for faricimab only recruited neovascular AMD patients that were treatment naive. This is an ongoing study that we are doing for over 4 years, as I said, and the latest data that we have today is over 3.5 years. To date, we have 3,675 eyes of 2,916 patients. We have over 21,000 intravitreal injections to look at in this study, and we're looking at different cohort of patients who receive 3 injections, 6 injections, 9 injections, and we continue to collect the long-term efficacy and safety data. So here are the demographics for the Truckee study. As you can see, most of these patients are switch patients. When we started this study several years ago, majority were the switch patients because in real world, physicians want to see the efficacy of a new drug in a patient that has persistent disease activity. But as the study has grown, more and more patients that are naive are being recruited. So let's look at efficacy. Looking at efficacy of all switch patients. So we have over 2,000 eyes in this cohort. What have we seen? We have seen that patients who were switched to faricimab are gaining on average about 10 days in treatment interval after switching. This is on top of stable vision and improve anatomy. The goal is that when you have a new treatment, you can hopefully control disease activity in patients with persistent fluid. And this is what we have seen in patients after 3 injections of faricimab, very similar to what was seen in the pivotal trials, where most of the improvement happened after the first injection, but patients continue to improve after 3 injections. What about patients who were on aflibercept 2 milligrams? We saw similar results. We saw that about a week of extension and stable vision with improvement in anatomy, which is highlighted by CST as well as PED height. Treatment naive are interesting because in TENAYA Lucerne, as you recall, had inclusion-exclusion criteria that limit real-world naive patients to be enrolled. This is all comers, including subretinal hemorrhages, patients with advanced disease. And what we have seen is that we are able to improve vision and anatomy after the 3 injections in naive patients and actually stretch those patients to about 49 days of interval right off the gates. What about fluid? When you look at fluid in all switch, aflibercept switch, as well as naive patients, you see a consistent data set, which shows that patients who are switched to faricimab or started faricimab are seeing improvements in intraretinal fluid and subretinal fluid over time. How about 9 injections? When you look at 9 injections, so this is longer data set. Remember, Truckee was enrolling patients with time. We didn't have all patients at the same time. So we have patients who are at 9 injections, patients who are longer. So right now, this is the longest follow-up we are presenting. And what we see here is that after 9 injections of faricimab, we are able to increase the interval in switch patients, and majority of these were very active patients, to 17 days with improvement in anatomy and stable vision. Similarly, for aflibercept switch patients, we see the same data set. So we are able to go from 2 milligram aflibercept to faricimab in patients who were previously treated and adding 2 weeks of interval on top of controlling anatomy and stable vision. In treatment naive, similarly, we have patients who are at 10 weeks of interval with improvement in anatomy and vision. Similar story here in terms of fluid, improvement in fluid in all patient subsets. Long-term visual acuity is improvement. We see long-term visual acuity drop off in patients in real world. Here we are seeing maintenance in switch patients and improvement in naive patients. In terms of interval, again, we're able to extend those intervals by switching to faricimab in both all switch patients and significantly in patients who are treatment naive. Fluid reduction, we have a sub-study looking at using AI to look at the fluid compartments, and we have seen rapid improvements in anatomy in patients on the left in all eyes, as well as patients who were switched to from aflibercept to faricimab after 5 treatments. So really showing that we are improving disease control by targeting VEGF-A as well as Ang2. And this is the total fluid reduction in the naive patients. Again, significant reduction after the first injection that continues over time, but mainly from the first 3 injections. Safety is a priority. Any new treatment that comes to the market, we have to look at safety. And Truckee was designed actually mainly looking at safety and, of course, learning about efficacy. We have seen an intraocular inflammation rate of 0.08% and endophthalmitis rate of 0.028%. The safety seemed consistent with other anti-VEGF that we have in the market. In conclusion, in the real-world setting with over 21,000 injections in 3,675 eyes, faricimab continues to demonstrate rapid improvement in all anatomic parameters, IRF, SRF, PED heights in both treatment-naive patients as well as previously treated patients. Benefit of faricimab increased with continuous treatment over time. Patients who were switched to faricimab from aflibercept after 9 injections added an extension of almost 2 weeks. And faricimab demonstrates a low rate of intraocular inflammation, which is consistent with other agents. We did have one reported case of non-occlusive vasculitis in this study that resolved with treatment and patient returning to baseline. Thank you very much for your attention.
Thank you. Excellent talk. Next, we have Jonathan Lin. He will be speaking on the risk of glaucoma after pars plana vitrectomy in a large federated health record network.
Thank you, Dr. Vanderbeek. I'm very excited to share our results today on behalf of my co-authors, Karen Wei, Prithvi Mruthyunjay, and Ehsan Rahimi. I have no financial disclosures, but my co-authors have a few that are listed here. So as we all know, vitrectomy is becoming increasingly common in the modern era due to improved instrumentation and surgical innovation. Almost 2 decades ago, Dr. Stanley Chang, one of the luminaries in our field, suggested that there may be a link between the vitrectomy and subsequent risk of open-angle glaucoma. And this is based on a case series that he published of almost 70 patients. He estimated based on these patients that up to 15 to 20% of eyes may be at risk for open-angle glaucoma after vitrectomy. And he hypothesized that this may be linked to positive oxidative stress, which may induce some cellular changes in the eye. Since this time, there have been numerous studies that have been looking at the possible link between these two, vitrectomy and subsequent open-angle glaucoma. But as you can see from this meta-analysis in 2018, there's a lot of heterogeneity in the findings of various studies. And as such, it remains unclear exactly what the risk is after vitrectomy. And this is not entirely surprising. As we all know, there's a lot of heterogeneity in the surgery these patients are undergoing, as well as the preoperative diagnosis that necessitated vitrectomy, which may cause a lot of differences in our patient population. And so we sought to use the Trinetics EHR network to try to answer this question better. As we all know, Trinetics is a very large EHR network of over 100 million patients. And so our goal was to quantify the risk. And our hope was that using large data, we may be able to get a better estimate of the true risk. And so of the 118 million patients in the database, we identified a retrospective cohort of over 42,000 patients who underwent a pars plana vitrectomy based on CPT codes between the years of 2013 and 2018. And of these patients, we wanted to follow them to see in the 3-month to 5-year period after surgery, what was their risk of glaucoma. And so we quantified this 3 ways. One, using new ICD-10 code diagnosis for glaucoma. 2, using kind of a new prescription for IOP lowering medications. And 3, identifying those patients who required incisional glaucoma surgery based on CPT codes. And of note, for these 42,000 patients, we identified those who did not have any prior diagnosis of glaucoma or prior diagnosis of glaucoma suspect or ocular hypertension. And we specifically chose to omit the postoperative period, kind of immediate postoperative period up to 3 months, because as we know, there's a lot of postoperative ocular hypertension, for example, that could be related to postoperative inflammation that may not be true glaucoma. As you can see, this is the demographic features of our patients. Their average age index was 59, with a roughly equal split between males and females. And you can see their ethnic and racial split here. So of our patients, you can see that just over 5% of these patients developed a new diagnosis of glaucoma based on ICD-10 codes within the 5-year postoperative period. And here you can see a Kaplan-Meier curve showing the event probability. And what's notable for this is you can see that the risk of glaucoma diagnosis actually remains similar across the time frame, even multiple years after the initial vitrectomy. One other finding is that it seemed that the glaucoma these patients were diagnosed with was relatively mild, because less than 1% of these patients required incisional glaucoma surgery over this time period. When we look at those patients and the requirement for IOP drops, you can see that just under 10% required new prescription for IOP drops in the 5-year postoperative period. And similar to the kind of event curve of the new diagnosis, you can see that, again, it's similar where there is, still a risk even multiple years after the index event of the surgery. Because of our relatively large numbers and the fact that we know that surgical factors as well as patient factors may influence this risk, we want to ask the question of whether preoperative diagnosis may influence this possible risk of glaucoma. And so we divided our cohort of 42,000 patients into those with a preoperative diagnosis of rhegmatogenous retractile retinal detachment compared to those with the preoperative diagnosis of ERM versus macular hole. And we propensity matched these cohorts to control for demographic features as well as systemic comorbidities that are known to influence risk of glaucoma. So when we substratify this data in this way, you can see that actually the risk of glaucoma seems to be higher in those patients with a preoperative diagnosis of retinal detachment. However, when you look at the requirement for IOP drops, the event probability is very similar between these. And this is not entirely surprising because, as we all know, IOP drops sometimes are used off-label for other reasons other than intraocular pressure alone. So in conclusion, based on data from this Trinetics database, you can see that the risk of glaucoma after vitrectomy appears to be just over 5%. And what's important is that this risk appears to be present even multiple years after the vitrectomy itself. And of course, the mechanism of this remains unclear, but our data suggests that the magnitude of this risk may depend on factors such as the preoperative diagnosis. I want to acknowledge our funding sources. And for those of you who want to dive into the data more, the paper is published in Ophthalmology Science at this QR code. Thank you for your time.
Thank you, Dr. Lin. Next, we have Rohan Bar-Singh discussing corneal opacity in the United States, analysis of the American Academy of Ophthalmology Intelligent Research Insight IRIS Registry.
Thank you, Dr. Vanderbeek. Good afternoon, and thank you all for joining. Today, I'll be presenting our work on epidemiology and surgical outcomes of corneal opacity in the United States using data from the IRIS registry. This study represents the most comprehensive national evaluation to date of both the burden and the real-world outcomes of corneal opacity. Corneal opacity is the pathological loss of normal corneal transparency resulting from disruption of the corneal architecture, thereby impairing optical clarity and visual function. It's the fourth leading cause of blindness globally, accounting for over 3% of blindness and more than 1% of visual impairment. While it's a major global problem, US-level data have been surprisingly scarce. Understanding who is affected, what causes their vision loss, and how outcomes vary is critical for improving eye care delivery and targeting resources. That was the motivation behind our registry-based analysis. The IRIS registry is a national EHR-based data repository established by the AAO. It captures clinical data from over 79 million unique patients evaluated by more than 16,000 providers across every US state. For each patient, it records demographics, diagnosis, procedure codes, and visual acuity measurements, making it ideal for longitudinal outcome studies. Our team accessed a de-identified version through the IRIS Analytic Center Consortium. Between 2013 and 2020, 5.2 million patients were diagnosed with corneal opacity in the IRIS registry, roughly 6.5% of all individuals. The average age was about 63 years, and nearly 58% were women. Most were white, followed by Black and Asian patients. About 1/3 of the cases were bilateral, showing the disease's potential for functional blindness. This tells us that corneal opacity is far more common in US practice than previously appreciated. The leading cause was corneal dystrophy, responsible for 2/3 of all cases, predominantly endothelial dystrophy, particularly Fuchs. The next major categories were corneal edema, ulceration, neovascularization, degenerative diseases, trauma, and infectious keratitis. Infectious causes, although less frequent than developing countries, still affected over 150,000 patients. Before diagnosis, the average vision was around 20/50, which declined to 20/60 at the time of diagnosis. Even after medical management, vision improved slightly but did not return to baseline. So most patients experienced irreversible vision loss once opacity developed. That's an important message. Medical therapy can stabilize but seldom restore transparency, emphasizing the role for surgical restoration when indicated. Our regression analysis showed that the baseline VA was the strongest predictor for the final outcome. Patients who presented with worse VA had worse final VA outcomes, Older age had a small but measurable effect. We also saw racial and ethnic disparities, with Black, Asian, and Native American patients had significantly poorer outcomes even after adjusting for other factors. And etiologies such as edema, trauma, and keratitis led to worse vision outcomes compared to corneal dystrophies. These findings suggest both etiological differences and inequities in access to early intervention lead to worse vision outcomes. Out of the 5 million diagnosed patients, about 44,000, that's less than 1%, underwent surgery for corneal opacity. The mean age of the subgroup was 67 years, again slightly older and had more females. Corneal dystrophy and edema were the top surgical indications, followed by non-infectious and infectious ulcers and trauma. Most patients, about 63%, underwent endothelial keratoplasty, including DSEK and DMEK. Penetrating keratoplasty accounted for 31%, and a small minority had ocular surface reconstruction procedures. This shift towards lamellar techniques mirrors broader US surgical trends, emphasizing faster recovery and lower rejection rates. The data also confirmed that endothelial disease is now the predominant reason for keratoplasty in the country. Across all surgical procedures, there was a significant improvement in vision was observed, from a mean of 0.72 to 0.56 logmar, or roughly a 2-line gain. Endothelial keratoplasty provided the greatest improvement, down to 0.41 logmar, while PK, the penetrating keratoplasty patients, started worse and their vision improved to 0.70 logmar. Even though the degree of recovery varied, almost all subgroups showed statistically significant visual gains. In multivariate modeling, we observed that baseline vision again dominated outcomes. The earlier the surgery, the better the final VA. Endothelial keratoplasty outperformed penetrating keratoplasty, consistent with the literature on DMEK's optical superiority and lower immunologic rejection. However, disparities persisted even within the subgroup, with Black, Asian, and Hispanic patients had worse postoperative outcomes even after controlling for baseline vision. This persistence suggests systemic inequities, perhaps differences in follow-up, comorbidities, or referral pathways. Clinically, we need to emphasize on early referral, particularly in patients with endothelial dystrophy before scarring occurs. From a systems perspective, expanding surgical infrastructure and corneal tissue availability, especially in underserved regions, is critical. Policy efforts should address racial and socioeconomic barriers to ophthalmic care. Finally, iris registry itself can be used for continuous quality improvement, benchmarking surgeons' outcomes, and tracking progress towards equitable eye care. Over the past year and a half, I've published a few studies specifically focused on the economic burden and outcomes in patients with cataracts, keratoconus, and AMD. The main goal of these studies was steering advocacy efforts in view of potential changes to Medicare and Medicaid reimbursements. And there are ongoing studies on diabetic retinopathy and glaucoma. I would like to thank this project was supported by the Massachusetts Eye and Ear Clinical Data Science Fund and was conducted in close collaboration with the Iris Registry Analytics Study Consortium. I would like to acknowledge Dr. Reza Dana and Dr. Thomas Dolman, under whose supervision these studies were performed, Dr. Alice Lorch, and Dr. Joan Miller, whose leadership guides the Mass Eye and Ear Data Science Lab and its research initiatives, and Dr. Jennifer Lindsay, under whose mentorship I'm conducting additional ongoing iris-based studies. Thank you.
Thank you. Very interesting talk. Next, we have, sorry, we have Parisa Amami discussing the clinical outcomes of suprachoroidal triamcinolone acetonide injection for non-infectious uveitis.
Thank you very much, Brian, and thanks to Rishi and Durga and the organizers for allowing me to present today. So I'm going to talk about the outcomes of suprachoroidal triamcinolone injection for patients with non-infectious uveitis, looking at the IRIS registry. Okay, these are my financial disclosures. Of note, I'm a consultant for Bausch & Lomb. Triamcinolone acetonide injectable suspension for suprachoroidal use was approved by the Food and Drug Administration for treatment of uveitic macular edema in October of 2021. Drug is delivered to the suprachoroidal space with a proprietary microinjector and distributes the medication posteriorly and circumferentially in the suprachoroidal space, facilitating more targeted delivery of the therapeutic agents to the posterior chorioretinal agents compared to intravitreal injection. PEACH3 study was a phase 3 randomized controlled multicenter trial, which was designed to show the efficacy and safety of the suprachoroidal triamcinolone injection. The study randomized the patients 3-2 to suprachoroidal triamcinolone acetonide injection group and sham injection group. The patients received injections on day 0 and week 12, and then they were followed for 24 weeks to assess the efficacy and safety of the suprachoroidal injection. And then the patients were allowed to be rescued if the best corrected visual acuity dropped or the central subfield thickness increased at the investigator's judgment. The primary efficacy endpoint of the study was the number and percentage of the patients who gained at least 15 ETDRS letters from baseline to week 24. And the study met its primary endpoint with 47% of the patients in the suprachoroidal triamcinolone acetonide group gaining that amount of vision compared to 15% in the control group. As far as the safety and adverse reaction goes, the medication and the study found the injection to be safe with a small percentage of the patients having headache, having eye pain, and so forth. And as you can see here, 7% of the patients in the treatment group compared to 6% of the patients in the sham injection group developed cataract, as well as increase in intraocular pressure, which was 14% in the two of the groups, which was not statistically significant. So this was the clinical trial, very controlled setting. How about real-world efficacy and safety of the medication? And how about longer duration of 48 weeks compared to 24 weeks? So we wanted to look at the real-world data. We looked at the American Academy of Ophthalmology's IRIS registry linked to Komodo adjudicated claims database from January of 2022 to December of 2023. We included all the adult patients with history of uveitic macular edema who received suprachoroidal triamcinolone acetonide injection and who had data in the registry for at least 48 weeks after the injection. And keep in mind that these patients only received one suprachoroidal triamcinolone acetonide injection compared to the PEACH3 trial. We excluded any patient with history of infectious uveitis in the 12 months prior to receipt of suprachoroidal triamcinolone acetonide injection. And again, keep in mind that compared to the study, we included everybody with any history of glaucoma or ocular hypertension. And in PEACH3 they excluded the patients whose eye pressure was more than 22 millimeters of mercury. So we included a total of 396 eyes of 357 patients between 2022 and 2023. The mean age at baseline was 67 years, and more than 50% of the patients were female. And as you can see here, 42% of the patients had history of glaucoma or ocular hypertension at baseline. So we found that by week 48, around 50% of the patients did not require an additional local corticosteroid injection. We also found that among those 50% of the individuals who did receive injectables by week 48, 27% of them received additional suprachoroidal triamcinolone, and 22% received local corticosteroids other than suprachoroidal injection. As far as the rate of IOP elevation goes, I compared our findings with Magnolia trial, and we found that elevation of 10 millimeters of mercury or more was seen in comparable number of the patients, 14% in our study compared to 14% in Magnolia trial, which was the 48-week extension after PEACH3. However, we found that the rate of higher increase in intraocular pressure, 25 millimeters of mercury or more, or 30 millimeters of mercury or more, was less frequently seen in our patients compared to controlled Magnolia study. So in conclusion, we found that 50% of the patients who received one suprachoroidal triamcinolone acetonide injection did not require a subsequent local corticosteroid in the 48 weeks after the first injection. We also found that among the patients who did receive a subsequent injection, 27% of them received additional suprachoroidal triamcinolone, and 22% received other types of local corticosteroids. We also found that the rate of increase in intraocular pressure was lower in our study compared to Magnolia and Peachtree study, despite the fact that about 30% of our patients at baseline had intraocular pressure of 22 or more. I would like to acknowledge my co-authors from Verana and Bausch and Durga Borkar from Duke, and thank you very much.
Thank you. And last but not least, for the speakers for today, we have Lucia Sobrin, who's going to be talking on vitamin D supplementation and remission from chronic anterior uveitis. Take it away, Lucia.
Thank you, Brian. Thank you for the opportunity to present our work. These are my financial disclosures, which are not relevant to this presentation. We examined chronic anterior uveitis, which is when anterior uveitis persists for 3 months or longer. This is an important disease because it's associated with a higher risk of cataract and glaucoma. It often requires long-term suppressive therapy, either in the form of topical steroids for prolonged periods or systemic immunosuppressive therapy, which represents an important burden to the patients. There have been several observational studies that have demonstrated an association between low vitamin D levels in the blood and uveitis, including some studies that link uveitis activity with the vitamin D level. In addition, in a Mendelian randomization study we performed, a genetically decreased vitamin D level was also associated with higher uveitis and scleritis prevalence, which suggests potentially a causal mechanism. So we hypothesized that vitamin D supplementation might be a remittive treatment for uveitis. And the purpose of the study was to evaluate whether there was a relationship between vitamin D supplementation and the incidence of chronic anterior uveitis remission in a real-world uveitis cohort. Part of the motivation for the study is that we proposed a clinical trial of vitamin D supplementation in CAU patients to the NIH, and we wanted to get a sense of what the effect size might be for vitamin D supplementation as part of the preliminary data for that grant application. The real-world data set we used was the systemic immunosuppressive therapy for eye diseases, or SITE study. The principal investigator on this is John Kempen. This was a highly structured chart review of uveitis tertiary care clinics across the United States. In essence, data entry personnel went to each of these sites. They entered into structured fields all the information for multiple visits on the patients. This chart review covered over 30 years in some clinics, and part of the structured fields included ascertainment of medications, supplementation use, and degree of inflammation as pulled out from the examinations. From the site database, we determined all the patients who had non-infectious chronic anterior uveitis of any etiology. Then we looked to see the exposure among the patients. Patients were included as taking vitamin D if they were taking any vitamin D dose. The dose ranged from 400 to 5,000 milligrams daily. We did exclude patients who were taking both vitamin D and calcium. This was to avoid confounding, because these two medications are commonly prescribed for bone protection during systemic corticosteroid use, and we knew that systemic corticosteroid use could confound outcomes for chronic anterior uveitis. The definition of our outcome was based on the standardization of uveitis nomenclature, expert consensus definition for quiescence for anterior uveitis, and patients had to achieve this definition on the examination while off treatment at all visits spanning at least 90 days. And the analysis was a Cox proportional hazards model. Here are the results. You can see on the x-axis the follow-up time in the database. You can see on the y-axis the probability of remission. We had only 75 patients who were exposed to vitamin D and over 2,500 patients not on vitamin D. But you can see at 16 months, which is chosen because that was the outcome definition, outcome time point for the clinical trial we were proposing, that the patients who were taking vitamin D had a remission rate of about 28%, whereas those who were not taking vitamin D had a remission rate of about 13.5%. This translated into an adjusted hazards ratio of 2.43, which was significant. And this analysis adjusted for many variables that we know, based on our prior studies, are associated with remission in chronic anterior uveitis and are listed here. The limitations of the study include that we don't really know why the patients were taking vitamin D. Some patients might have been taking it because it was recommended by their primary care for vitamin D deficiency. Others might have been taking it for other perceived health benefits, started on their own. And so there may be some underlying confounding by the indication for vitamin D. There are also other limitations that have already been touched on in this summit inherent to retrospective research. There are irregular follow-up visits, which made it difficult to have a perfect remission definition. We didn't have a lot of dosing information on some patients, and so we couldn't do a dose-response relationship evaluation. And of course, because this was done in uveitis tertiary care centers, the cases of uveitis were likely more severe than the average case in the population. And so that may also influence the generalizability. In conclusion, this is an initial look at the association between vitamin D use and the incidence of chronic anterior uveitis remission, and it suggests that vitamin D supplementation may be valuable to increase this remission. We think whenever feasible, this kind of observational research is a logical first step to evaluate the treatment effects that we hypothesize may be beneficial to our patients, but really more investigation is needed before we can recommend these treatments as a remittive treatment, in this case for chronic anterior uveitis. I want to thank all of the collaborators from the different sites from which the patients were derived. I also want to thank our funding from the National Eye Institute for the site study and some additional funding from Research to Prevent Blindness and some of the sites that were involved in this study. Thank you very much.
Well, thank you. Thank you to all the afternoon speakers. Excuse me. Wonderful talks. We do have time for a couple of questions if we could. We had one question in the chat. Dr. Kanani, and Chucky, are there patients who may have been switched from faricimab at some point in their treatment journey, potentially to aflibercept 8 milligram, or if not, an analysis about any patients who may have failed extension? Anything about characteristics of difficult to treat patients who may not achieve durability?
Thanks, Brian. That's a great question. And obviously, we are lucky as a field to have both faricimab and aflibercept 8 milligram available to get better durability for our patients. So we do have a subset of patients in Truckee that are switching from faricimab to other drugs for certain reasons, whether it's the foundation copays, whether it's lack of durability. So we know that, when you look at patients, especially previously treated patients with wet AMD, they could have high VEGF load, they could have other mechanism like Ang2 in action. The challenge has been, of course, the numbers and the label. Most of the patients who were previously treated on aflibercept 2 milligrams, switch to faricimab, they're adding 1 to 2 weeks on average in durability. And the limitation of the 8 milligram is that the label that we can only use it monthly for 3 months. And after that, you have to go to 8 weeks of dosing. So I think that's why the numbers are small, but we are definitely looking at patients who are switching from faricimab to other drugs, and that data will be presented in the future.
Very good. Thank you. And Lucia, if I could ask you, you're amassing quite a wealth of data to argue for vitamin D supplementation, although you're holding off and actually suggesting that we do that. Are you waiting for the clinical trial, or I guess similar to what I was asking Dr. Bolin, what is going to be your tipping point for when you would start to recommend it?
Yeah, we're waiting for the clinical trial. I think that that's always the gold standard for recommending a treatment. These studies, as have been discussed already on some of the others some of the other sessions, these studies still have uncontrolled biases that make them difficult to base clinical decisions on with confidence.
And Dr. Amami, who would be your prototypical patient you would use the suprachoroidal triamcinolone injection on?
So obviously they have to have uveitis, like the uveitic macular edema patients. Yeah. And then the medications that we currently have on the market for these patients, like intravitreal dexamethasone implant, fluocinolone acetonide injectable implant, or the surgical implant for fluocinolone acetonide, all of them come in with high risk. All of them are steroids. So like all of the steroids come in with the risk of cataract, glaucoma, ocular hypertension, and so forth. Based on these data, I have been a little more open to using suprachoroidal injection in patients with ocular hypertension and glaucoma at baseline, given that in a lot of the local steroid injection studies, they excluded the patients with history of uncontrolled glaucoma and ocular hypertension, including the Peachtree and Magnolia studies. But then our study, because it was IRIS registry, all comers were included. We did include individuals with glaucoma, regardless of the number of the medications that they were using and regardless of how high their IOP was at baseline. And we didn't see a huge increase in the intraocular pressure or rate of glaucoma surgery and so forth. So that would be my probably, like, I still have the conversation with the patients that, hey, it's a risk that it can happen. And this is a good data, but keep in mind that the patient population that we see in tertiary uveitis clinics are different from IRIS registry. IRIS registry data comes from mostly private practices, so not very severe glaucoma or uveitic, non-severe uveitis or uveitic glaucoma patients. So patient populations are different. We need to keep that in mind as well. But yeah, with these data, I will have a little more confidence in patients with higher IOP at baseline with a lot of caveats.
Thank you. And Dr. Lin, you showed a nice graph that had nice separation between the TRDs and the epiretinal membranes for glaucoma, and yet the use of drops kind of overlapped in the two. Why do you think that was, and why do you think we didn't see more separation?
Yeah, it's a great question. I think as we know, people start IOP drops for a variety of reasons, such as sustained macular edema. A lot of people will use like topical carbamazepine anhydrase inhibitors, for example. And so I think we suspect that that's related to kind of off-label use of the drops for non-glaucoma reasons.
All right. Well, we've run over, so thank you again to all of our speakers today. It was an excellent session all the way through. I want to thank the organizers as well as my co-moderators, Dr. Rishi Singh and Dr. Durga Borkar. And thank you to our sponsors, of course, and hopefully we will see you all again next year. Thank you all.
Bye-bye.
Bye.
Thank you.